I don't know whether once they say then we'll share.
Oh,
So, sir, we are on live, sir, and we are starting the session, sir. So, very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for this webinar in this wonderful evening. Shield Healthcare feels proud to be the part of program by joining hands with Chalisgan Obesian Society. I take my pleasure to welcome the guest of honors, the chief guest, the organizers, conveners, the chairpersons, and the speaker for today's session. We have interesting topics today to be discussed by the experts. I would like to welcome the hand over the session to Mrs. Karishma ma'am, who is going to be the master of ceremony for today's session. Welcome, Karishma ma'am, or to you, ma'am.
Thank you so much. Moving on, I would request Dr. Ajay Mane. I would request and invite Dr. Ajay Mane, the convener of this webinar. Dr. Ajay Mane is member of NIMC committee, PCPND wing, Government of India, medical legal consultant since 18 years, and sir is giving advice for free of cost since 18 years. He is also chairperson, official AMOG's website, chairperson, Sexual Medicine Committee, FOXY, chairperson, Adolescent Health Education Committee, AMOGs, joint secretary, AMOGs, past president, Aurangabad OBGY Society, national trainer, FOXY Adolescent Health Committee. He has 9 national and 4 international publications, authored topics in various FOXY focus and various books, former superintendent, MGM Medical College, Aurangabad, health advisor, Sports Authority of India, charter president, Rotary Club, Aurangabad, Elite. Now, I would request Dr. Ajay Mane, sir, to introduce and invite Dr. Mahesh Tandale, MMC Observer, to share some words of wisdom for this webinar. Over to you, sir.
Thank you. Thank you, Karishma. And at the outset, I must convey my gratitude to Chalisgan Obesian Society, who is happy to be our organizers part. Thank you, Karambalkar sir and Yashwant Pawar sir. And I'm inviting Dr. Mahesh Tandale.
He will be joining late. He will be joining late.
Okay, I'll introduce him. Whenever he comes,
Yes,
he'll be giving his opinion. Studied at MGM Medical College, Aurangabad, and fortunately, I am his senior. Studied at JJ Hospital and Grand Medical College, Mumbai for his post-graduation. He's associate professor in Indian Institute of Medical Sciences and Research, Varudi, Badnapur, Jalna, and he's known as Google of Aurangabad Obesian Society. Very knowledgeable person, very academic, thorough academic person. Whosoever want to have proper academic knowledge, they call him.
Dr. Ajay, your voice is not audible. So is it not audible for me or for everyone?
We can hear.
Am I not audible?
Audible.
Okay. Yes, yes. Loudly, Dr. Ajay, loudly.
Yes. Just a minute. Fine. Okay. I welcome Dr. Mahesh Tandale. He's not there. Whenever he comes, so we'll take his opinion. Now we move on to our chief guest. Can I have the slide, please? Yes. Our chief guest is Dr. Achala Batra. She is a professor of Obstetrics and Gynec, VMMC and Safdarjung Hospital, New Delhi. She is president, Association of Obstetricians and Gynecologists of Delhi, 21 to 22. Then she is a president, National Association of Reproductive and Child Health, Delhi, 18 to 20. She is a member, Urogynecology Committee, FOXY. She is contributor in Government of India manuals. She is a reviewer of indexed journals of obstetrics and gynecology. Then she is author workbook of obstetrics. Then she has got papers in national and international journals. She is ex-editor AOGD and ex-editor NARCHI, and she is teaching undergraduate and postgraduate since 40 years. A great personality, a thorough academician, and a very knowledgeable, stalwart personality. I welcome Dr. Achala Batra ma'am and request her for the opening remarks as a blessings. Achala ma'am.
Thank you, Ajay, and thank you, Chalisgan Society, for inviting me. This, the good part of COVID is that we are connecting with so many people all around the nation, otherwise we never meet these people. So something good COVID has brought, that it has brought, everybody together. And a very interesting pre-webinar discussion I was witnessing. And I really like that part of webinars, the pre-webinar when everybody is meeting and talking informally. That is really nice. And today's topic is very relevant because in our country, infertility is a big problem. Not only for affluent, also for poor because they are afflicted with some tuberculosis or some other problem. Affluent because they don't plan their pregnancies in time and then they have this problem. So it is very popular, and because the results are not 100%, that is why the ART people are always striving to do new things, to come out with ways with which they can improve the results. And there are so many nuances to it. And I think quite a few of them are being covered, the surgeries, the induction protocols, and the most important, the medico-legal aspect in which ART people are totally embroiled at the moment, and what is new. So it's really nice to meet everybody. Dr. Gnrh Singh Pardesi, Dr. Ajay Mane, Dr. Vinita, and the office bearer of Chalisgaon. It's good to meet everyone, and Shivani, of course, from my own city, whom I keep seeing and very active in everything. So I think everybody is going to like this webinar. I can see all the people are very, pioneers in their field and very, very experienced. So everybody is going to learn from it, and I wish this webinar a great success.
Thank you so much, ma'am, for gracing this webinar.
Thank you. Thank you, madam. Now we move on to our guest of honors, and the first guest of honor is, can I have the slide? Yeah, Dr. Asha Rao, who is the chairperson, Endometriosis Committee, FOXY 20 to 2022. She has got experience of 25 years in ART. She's at present director, Rao Hospital and Care, Coimbatore. She's a director for postdoctoral fellowship program in reproductive medicine and endogynecology, and is affiliated to Tamil Nadu Dr. Mgr Medical University, Chennai. She's past president, Coimbatore OB/GYN Society, 2017 to 2019, and in 1993 to 1994, when I was in third year, basically. She was organizing chairperson Endo Insight 2021 International Endometriosis E-Congress with the FOXY and SEUD. She is organizing chairperson UFOXY South Zone 2019 at Coimbatore. We have attended it. It was a very nice experience there.
Thank you, Dr. Mani.
Yes, ma'am. Yes, a very nice conference. Organizing chairperson IAGA Star Endogen Conclave 2019 Coimbatore. Then she was organizing chairperson for the 8th National ISAR Conference in 2001. She has got gold medal from President of India and from University in the final MBBS. I am amazed that I think I have read so many biodatas. Very few male got gold medal, but many women got gold medal. They fond of gold, I know, but in form of medals,
I know.
So I congratulate madam. I welcome you and request you for the blessings.
Yeah, namaste. Good evening, all of you. And thank you so much, Dr. Ajay Mane, for the kind words and for having invited me here. Thank you, Dr. Rajendra Pardesi. They're always the smiling and dynamic people from Aurangabad. I meet them at most conferences. And today it is such a prestigious meeting and a very important topic of infertility. And we have such stalwarts here. Speakers like Dr. H.D. Pai, Dr. Manju Jilla, Dr. Lokhande, Dr. Shivani, all very, very active and dynamic people and very interesting topics. And Dr. Ajay Mane has been very active in the field of medico-legal. I mean, I really appreciate the way he has been giving so many lectures in very many aspects of medico-legal problems that they have been troubling. And every day the problems are becoming worse. And it's very nice that he's helping so many people. And I wish you all the best for your forthcoming election, Dr. Ajay Mane. I'm sure you are a winner. And Lovely meeting you, Dr. Vinita, Dr. Rajashri, and Dr. Achala. And let me not stand between the audience and the lovely topics. So wish you all the best, Dr. Mane, and let us go ahead with the meeting. Thank you.
Thank you. Thank you, madam. Thank you, and best luck to your son from all of us.
Thank you. Oh, thank you so much.
Yeah,
Especially for that.
Definitely will.
Thank you.
Yeah. Best luck.
Yeah.
Now we move on to next guest of honor. That is none other than Rajeshri Palladi, madam. Can I have the slide, please?
Yes, sir.
And can I have the slide? Yes. She is a professor and head of Department of Obstetrics and Gynecology, KBN Institute of Medical Sciences, Gulbarga, very near to my hometown. She is a chairperson of Genetic and Fetal Medicine Committee, Kasoga 21 to 22. She is president, Kalaburgi Obstetrics and Gynecological Society 2021. She is vice president, Rotary Club, Kalaburgi 2021. Then UG and PG examiner at Karnataka, Maharashtra, Telangana universities. Gold medalist OBG, say, see, I told, no, they are gold medalist always. Then GSE team member of Rotary International, great. And interests are high risk obstetrics and fetal medicine, very knowledgeable and great academician, Dr. Rajeshri Palladi, madam. I request her to give the opening blessings.
Good evening, everybody. Thank you very much for the kind words, Dr. Ajay. And I thank the organizers for giving me an opportunity to share the platform with such stalwarts across the country, right from Delhi to Coimbatore. And then we have such an august audience and august speakers to share their knowledge on this platform. And just as Madam said, it's truly wonderful that the COVID has brought us together and we can actually see face to face many of us who would fail to meet each other in years or in months. And now we can directly talk to each other and share the knowledge. And in fact, I think the maximum knowledge sharing has happened during the COVID times with 1 or 2 webinars every day. And truly, the topics chosen for today are extremely wonderful. And I would love to listen to Dr. Ajay. I have heard him, I have seen him giving wonderful talks, addressing the Kasoga as well. Recently, we heard him talk about cesarean section, and Dr. Vikram Lokhande and Dr. Manju Jilla. Dr. Manju Jilla, I have attended the Aurangabad conference, the national conference conducted there, and we have seen such a wonderful program that was. Dr. Asha and Dr. Adinath, it's a great pleasure to be introduced to you all on this platform, and wonderful that so many friendships, fellowships are going on. And except that for the food and drink, maybe we miss, but absolutely this has been a gorgeous, gorgeous platform for us to all meet together. Thank you so much, and wishing the program a grand success.
Thank you, madam. Thank you very much for the blessings. And
Ajay,
as you said, sir.
Dr. Mahesh is there.
Okay. Hello. Can I? Okay, Mahesh. Yeah. Can I request Dr. Mahesh Chandre, who is our MMC observer, to kindly say a few words?
Thank you, Dr. Rajeshri. Thank you so much.
Thank you so much, sir.
Mahesh, you are muted. Unmute. Hello.
Good afternoon, everybody.
Yes. Biodata. Ajay. Biodata.
Thank you. Already lot of delay. We can start the CME because there are so many solvers, so many senior teachers waiting, and everybody is waiting to hear them. So it is better to start as early as possible.
Thank you, Dr. Mahesh, for the remarks, and we request you to be there till the end of the webinar. Thank you very much.
Okay.
Yeah. Now I invite the next guest of honor, Dr. Vinda Singh, who is the president of Patna Obstetrician Society, past chairperson, YTP committee FOXI. Yes. Her professional designations are associate professor, Department of OBGYN, ENMCH Patna, then consultant, Care Hospital and IVF Center. At present, holding the post president, Patna Obstetrician Society, that I told you, and posts held FOXI ICOG Governing Council member, then YTP committee chairperson FOXI 17 to 19, joint secretary, clinical secretary, treasurer, vice president, executive committee member of POGS, a member of Safe Motherhood Committee, Quiz Committee, Practical Obstetrics Committee, FOXI, Business Secretary, the Partner Journal of Medicine, East Zone Coordinator, MTP Committee, FOXI, and conferences and workshops. She has organized, is organizing secretary Nikon 19, invited faculty in workshops FIGO, Rio 2018, participated in FIGO, Vancouver 2015, organizing secretary of BoxCon 2016, invited faculty in multiple national and local conferences, and she has edited a FOXI ICOG campus on PCOD, a great journal. Then she has got awards, to say a few: MG Mishra Award in 2004 and George Mohani Award in 2012. I welcome Vinda Singh Madam and request you to kindly say a few words.
Thank you, Dr. Ajay, for your kind words. Very good evening and warm greetings on behalf of Patna OBGYN Society in today's webinar, which is going to be held on such an important topic, that is infertility update. The bond that link is not only blood, but respect and sharing joys and sorrows in each other's life is true family, and that is our FOXI family. And whenever we see everyone, we feel so happy. I'm really privileged and honored, and at the same time highly grateful to Dr. Rajan Singh Pardesi, past VP FOXI, who always guide me, for giving me opportunity to share the platform in which so many stalwart FOXians, especially President-elect 22-23, Dr. Rishikesh Pai will be delivering his talk. And what about Dr. Ajay Mane, a brilliant FOXian? My best wishes to you, Dr. Ajay, for your forthcoming election. And I think you will be one of the winning candidates. You will be VP in the near future. I'm really feeling honored to see so many friends of mine, Dr. Manju Jilla, Dr. Lokhande, as a speaker, and especially to see my friend Dr. Asha Rao and Dr. Shivani Sachdeva Gaur, and so many, and Dr. Achala Batra ma'am, President of Delhi OBGYN Society. I wish all the best for the webinar to be a great success and informative one. Once again, I would like to thank Rajendra sir for giving me opportunity to be the guest of honor in this prestigious webinar. Thank you very much.
Thank you, Vinita Madam. Thank you for the blessings. Now I invite Dr. Rajan Singh Pardesi sir, our own backbone of our OBGYN Society, and my mentor.
It's okay, Ajay, no, we are lagging quite behind schedule.
Okay, just one sentence.
Thank you.
No, one sentence. 6 times best paper award in FOXI, the highest one. So I welcome Rajendra Singh Pardesi sir.
So I wish every success to this webinar. Congratulations, Chalisgaon OB Society, and thanks to Dr. Achala Batra ma'am, Dr. Vinita, Dr. Rajasri Paladia, and Dr. Asha Rao madam for gracing our webinar. Thank you so much. And again, wishing you best, Dr. Ajay, for his Vice President FOXI election. And I wish every success to the Chalisgaon Society, Dr. Yashwant Pawar, Dr. Karambalekar for this webinar, and to all the faculties and chairperson. Thank you so much.
Thank you, sir. Thank you very much. Over to you, Karishma, for the further proceedings.
Thank you, sir. Now, moving on to our scientific session, I would like to introduce and invite Dr. Adinath Rajguru and Dr. Shivani Sachdev Gaur to chair the session as chairperson. Can we have the CV, please? Yeah, thank you. So, Dr. Adinath Rajguru, past president of Usmanabad OBGYN Society, Director Rajguru's IVF Akshay Hospital, Usmanabad, participated as faculty in MRCOG conferences from Marathwada region. Dr. Shivani Sachdev Gaur, MD DNB MRCOG UK, Director SCI Healthcare, Fellow Member Imperial College, Founder Secretary Delhi State Chapter of ISAR, Secretary Delhi State Chapter of ISPAT, General Secretary INSTAR, ex-VP Delhi Gynae Forum South, Vice Chairperson of Women Director Wing IMA South Delhi, number of publication more than 10, special awards and recognition, Rashtra Gaurav Sanman 2015 and Rashtra Ratna Sanman from Minister of Women and Child Welfare, Government of Delhi, member of Editorial Board of International Journal Reproduction, Contraception, Obstetrics and Gynecology in the LIMCA Book of Records for Surrogacy Public Awareness Organization by India Society of Third Party Assisted Reproduction, widely quoted in national and international media. I would request Dr. Adinath Rajguru to introduce and invite Dr. Manju Jila to talk on recent updates in ovulation induction protocols. Over to you, sir.
Rajguru, sir. Dr. Adinath Rajguru.
Sir, no, sir, I can't.
Adinath is not there.
Okay, then I would request Dr. Gaur ma'am to introduce and invite Dr. Manju Jila to talk on recent updates in ovulation and induction protocols.
Can we have the slide, please? Yeah. Shivani ma'am?
Yes, yeah, hi.
Yeah.
It is a great honor to invite Dr. Manju Jila ma'am, Dr. Gnrh Singh, Dr. Ajay. Thank you so much for this opportunity. She is the director of 60-bedded multi-speciality hospital with focus on OBGYN and infertility treatment and more than 5,000 successful pregnancies with IVF, 8,000 laparoscopic surgeries.
Little less, just 1 or 2 lines and we start off.
And she is so good. She has given guidance to so many labs to set up and PhD in biotechnology with past president of Aurangabad Society. Great honor, ma'am. Welcome. We are looking forward to your presentation.
To tell a specialty about Dr. Manju Jila, she's a pioneer in IVF in Marathwada region, basically. She has got one international center in Dubai also.
I know. Hello.
Yes, ma'am. I welcome.
Can you hear me?
Yes, ma'am.
Yes, ma'am, very clearly.
Yeah, I am proud to be from Aurangabad, a place from where we are having our own contestant, Dr. Ajay Mane. And today's opportunity to talk, I have specially taken because I want to tell everyone to support him because I know him since years together, a very, very selfless person in helping everyone. So my first request is that all of them who are attending this program today, please support Dr. Ajay Mane, who is from my town and I'm very proud of him. Let's talk about ovulation induction.
Thank you.
All of us who are treating infertility patients should understand the hypothalamo-pituitary ovarian axis, the details about the different hormones which are interplaying so that we can induce ovulation in anovulatory ovaries or ovulating ovaries for IUI or IVF. So we'll just clear up our basic concepts and let us understand that induction of ovulation is done when the ovary fails to ovulate. But superovulation is done in an ovulatory ovary to get extra follicles for increasing the chances of conception. So ovulatory disorders, that is anovulation, which usually presents as irregular menstrual cycles, is found in 25% of female infertility cases. And the creation of a mature oocyte is controlled by a very complex feedback system that requires extensive coordination between hypothalamus, anterior pituitary, and the ovaries, as well as the local factors produced by the ovary and the external endocrine factors. Dysregulation at any point in this pathway may result in pathologies culminating in ovulatory dysfunction or even ovarian failure, and patients often present with infertility. So we all know that production of the oocyte begins at 6 to 8 weeks of gestation when the primordial germ cells first undergo mitosis and then meiosis to produce a primary oocyte that is housed in the primordial follicle within the ovarian cortex. These primordial follicles are surrounded by a single layer of granulosa cells that are arrested in the diplotene phase of meiosis 1 until the onset of menses. Though approximately 1 million oocytes are present in the ovary at birth, only 400 to 500 ovulate throughout the childbearing years. The primordial follicle continues to develop into primary, then secondary follicle, which is surrounded by granulosa cells that contain FSH receptors and theca cells. During these phases, the growth of the follicles is independent of gonadotrophin. That is, till they become preantral. Majority of the follicle at this point will undergo atresia. That is, if about a 700 to 800 follicles, primordial follicles become primary, only a few hundred will become secondary, and only say 80 or 90 may become pre-ovulatory, and 5 or 10 will become antral. So ovary houses all these are the primary, the secondary follicles, and then it is these preantral follicles which secrete AMH, and once they get a FSH receptor, then they no more secrete AMH but start growing and producing estradiol, which is responsible for the regular menstruation and the regular interplay between the hypothalamus, pituitary, and the ovary. By immunohistochemistry, it was shown that a cut section of ovary has got different types of follicles at different stages. Some are primordial, others are primary, then secondary, antral, and pre-ovulatory. This is actually a real immunohistochemistry photograph of a cut section of a human ovary. Now let us understand this interplay, and this is extremely important. I'm going to take some time on this slide. Now, here is we know that we only always think that GnRH stimulates the pituitary, which leads to release of FSH-LH, and then the antral follicle, the theca cells have got receptor for LH, the granulosa cells have got receptor for FSH, and once the estradiol, by the two-cell theory, once estradiol is produced, that is from testosterone with the help of aromatase enzymes, estradiol is produced. This estradiol has got a negative feedback effect on the release of FSH. Now, GnRH does not have any estradiol receptors, the GnRH neurons. Let us understand which all hormones is our HPO axis producing and how do they act. Estradiol and progesterone, these are steroid hormones. In our body, steroid hormones will act on multiple cells. They just enter the cells and their receptors are either present in the cytoplasm or nucleus of the cells. So whenever estrogen, progesterone, testosterone, corticosteroids increase, you will see a change in the general body appearance of that person. Like a girl undergoes puberty and starts looking like a woman because of estradiol. So estrogen will act wherever it has got, or in most of the cells where it has got a nuclear receptor. Whereas these hormones in the preoptic area of the brain, they control GnRH. There are 3 types of hormone produced in the preoptic area of the brain called as neurokinin B, kisspeptin, and dynorphin. These are small peptides. Now, protein hormones do not enter the cells. Peptide hormones have got very short half-life, very short. In few minutes, they will disappear. So these control the pulses of GnRH, kisspeptin, neurokinin B, and dynorphin, which are secreted by the neurons in the preoptic area. Now, GnRH is a decapeptide having 10 amino acids, and it acts on the outer surface. So again, this is a protein or a peptide hormone. So it has got a specific receptor on the surface of the anterior pituitary cells, which in turn stimulate the transcription factors for production of FSH and LH. Now, FSH and LH are glycoprotein hormones. They have got an alpha chain, they have got a beta chain, and they have got a carbohydrate moiety. That is called as the sialic acid. More the carbohydrate in these gonadotrophins, longer is their half-life. Now, the LH has got minimum carbohydrate, just one sialic acid molecule. And so its half-life is just 30 minutes. Whereas FSH has got a larger amount of carbohydrate in it, attached to the alpha and the beta chain. And so its half-life is around 3 hours. And a similar beta chain like LH is present in HCG, human chorionic gonadotrophin, produced by the placenta. but it has got a larger number of carbohydrate molecules attached to it. Therefore, HCG acts in the same way as LH because the beta chain gets attached to the receptor on the theca and the granulosa cells. So it acts same way as LH, but as LH has only a half-life of 30 hours, the HCG has got a half-life of 36 hours. Therefore, instead of using LH to rupture the follicle or to bring out a surge whenever we are inducing ovulation, we use HCG. So protein hormones do not enter the cells. When they are glycoprotein, they have a longer half-life. When they are just peptide, they have a shorter half-life. Each of them have got a receptor and they act only and only on a specific cell. Like whatever is the level of FSH, LH, GnRH, kisspeptin, dynorphin, you will never see syndromes. No other organ, no other cell will be affected by these protein hormones except their single target cell. Whereas if the steroid hormone increase, you will see syndromes where majority of the organs or cells will be affected because these steroid hormones enter the cell and act on the transcription factors of the cells. Now, what happens normally, I told you that estrogen has got a negative feedback effect on the higher neurons, and that reduces the GnRH pulse and that reduces the FSH secretion. So at the start of menses, when progesterone or the corpus luteum dies, inhibitory effect of progesterone on these neurons is gone, GnRH pulse increases, FSH levels start increasing, a cohort of follicles start growing, and as these follicles start producing estradiol and inhibin, the level of FSH decreases and only one follicle grows and all the other undergo atresia. This follicle grows for about 10 to 12 days under effect of minimum FSH. And as it is growing, it goes on producing more and more estradiol. These granulosa cells also secrete certain factors which increase the LH receptors on the theca cells. And at a specific level of estradiol, more than 200 picograms, there is release of kisspeptin from the preoptic area, which causes a sudden surge of GnRH and a sudden release of LH, and therefore a rupture of follicle by the 12th to 14th day. Once the follicle ruptures, the oocyte enters the fallopian tube, and what remains behind is a corpus luteum, which now starts secreting progesterone. And this progesterone is again inhibitory to these higher neurons and to the pulses of GnRH, and therefore minimum amount of LH is secreted, which allows the corpus luteum to survive only for 14 days. At the end of 14 days, the corpus luteum will die unless there is a pregnancy and beta HCG starts coming from here and acts as the LH surrogate and allows this corpus luteum to live for 7 to 8 weeks. So if corpus luteum dies, progesterone falls. If progesterone falls, new FSH and GnRH pulses will start getting secreted, and fall in progesterone level will produce menstruation because endometrium in itself cannot grow. It is completely dependent on estrogen and progesterone. The moment the levels of estrogen and progesterone fall, the endometrium, the superficial layer of endometrium starts shedding, and that is a normal menstrual cycle. And a new cycle will start because now there are no steroid hormones. There is no negative feedback on the higher neurons. So GnRH pulses will increase. FSH again will start growing. And the new group of follicles which has become antral will now start growing again. So this is how the interplay of hormones, the steroid hormones, the peptide hormones, and the glycoprotein hormones act along with the intra-ovarian factors producing estrogen and progesterone. So proliferation of supporting granulosa cells and theca cells create fluid-filled spaces called antrum. Once this is formed, the follicle becomes dependent on FSH for continued growth and development. During the latter half of this portion of the follicular phase, the follicles may be referred to as antral follicles, graphene follicles, or pre-ovulatory follicles. Although multiple follicles are recruited each month, it takes several menstrual cycles for them to become mature and achieve a pre-ovulatory state. So a primordial follicle to become a pre-ovulatory follicle, it takes almost 7 to 8 months for it to become primary, then secondary, then preantral, and then antral. When the threshold levels of FSH is reached during the time period known as the FSH window, a set or cohort of pre-ovulatory follicles is recruited. These follicles are able to respond to rising FSH-LH levels, secrete estrogen and continue to grow. One follicle responds more robustly, creating high estrogen levels within the follicular microenvironment through aromatase activity and generating a higher concentration of FSH receptors, which perpetuate this follicle to grow. And remaining pre-ovulatory, and the other follicles, because they have less FSH coming on them, they undergo atresia. So here we see a very common picture which we see in most of our physiology books. What happens? That is when the menstruation starts, when the corpus luteum dies, the menstruation starts, FSH levels start rising. So these are high FSH level. As estrogen levels increase, the FSH levels start falling. Then at the peak level of estrogen, there is a LH surge. And after the LH surge, we see the progesterone levels start increasing. And at that time, LH and FSH levels become very, very low. So this is a normal hormonal pattern of a menstrual cycle. And in response, the endometrium is becoming proliferative and then secretory, ready to take an embryo on it. At the same time, okay, we have already discussed this. So this is how a follicle, an antral follicle looks. These are the theca cells. This is a membrane. These are the vessels between the theca and the granulosa cells. This is a pond containing estradiol. This is the oocyte surrounded by a layer of granulosa cells. The granulosa cells have got a very specific enzyme called aromatase. And it is this aromatase which converts testosterone to estradiol. So from the blood, cholesterol is taken up by the theca cells and converted to testosterone. This testosterone is taken up by the granulosa cells, and the aromatase enzyme in the granulosa cells converts this testosterone to estradiol. All this happens under effect of an FSH which is stuck to the surface receptor of the granulosa cells. So theca cells surrounding the dominant follicle contain LH receptors. In response to LH stimulation, the theca cells produce steroids, the precursor necessary for production of estrogen via aromatization. As estrogen levels continue to rise, FSH activity switches to increase the concentration of LH receptors in the granulosa cells. Once a peak level of estradiol is reached, the hypothalamus is stimulated, that is kisspeptin is released, which causes surge of GnRH, which causes surge of LH. So I have put my own handwriting in a very bad way. There is a pencil which writes on the computer, but it slips. Anyway, what I want to say is there can always be problems anywhere in this entire HPO axis. One is that GnRH may not be produced by many single gene disorders. There might be a single gene disorder in the kisspeptin gene or in the GnRH gene or in the LH-FSH gene. You know, there is a Kalman syndrome which causes low FSH, LH and anosmia. So many single gene disorders can produce hypogonadotrophic hypogonadism. Postpartum pituitary necrosis because of hypotension produced because of hemorrhage can also destroy the anterior pituitary, leading to hypogonadotrophic hypogonadism. So if FSH, LH is not secreted, there is a problem in this cyclic menstruation and the interactions between the estrogen, FSH and LH. Now, if there are too many follicles in the ovary, too much of theca cells, too much of androgens in the ovary, many follicles come to the surface. Together they produce more estrogen, which does not allow a falling and rising level of FSH, and that produces chronic anovulation, which is seen in polycystic ovarian syndrome patients. Some rare group of patients may also have single gene disorders of FSH and LH receptors, who may just not respond to any hormones of ours, even if they have a lot of follicles inside. This is a very small group, but we must understand that there can be patients who may not even respond to gonadotropin, although having very high AMH levels. And the last is the ovary may just not have any follicles, that is no granulosa cells, no theca cells, no oocyte. So where is the FSH-LH going to act? However high the FSH-LH is, it is not going to act. And this is ovarian failure or premature or mature menopause. But see, next. So WHO has divided anovulation into 3 types. Hypothalamo-pituitary failure, I told you, where FSH-LH is very, very low, pituitary fails to produce FSH-LH. So naturally, the follicles are not going to grow. No, there's going to be no action of aromatase in the granulosa cells or no conversion of cholesterol to testosterone by the theca cells and no production of estradiol. And so the follicles remain quiet, unstimulated, like they are in a little girl. Then when the FSH-LH levels are normal, that is group 2, this is a huge group. 80% of the anovulatory patients have a dysfunction hypopituitary ovarian axis, which is seen in PCO or adrenal hyperplasia. And the last is where FSH-LH levels are very high, that is when there are no active or no follicles present in the ovary. So group 1 describes 5 to 10% of anovulatory patients with dysfunction in the HPO axis demonstrated by low or sometimes normal levels of gonadotrophin, or actually that is usually less than 1. Without an intact HPO axis, WHO group 1 patients are unable to respond to FSH-LH and therefore do not recruit any follicles or have appreciable increase in estradiol. Because there is no FSH-LH, there is no estradiol production. As these individuals have underlying low level of estrogen, supposing they come to us with a secondary amenorrhea and you give a progesterone withdrawal test, it will not happen because endometrium is not primed with estrogen. They will have a scanty endometrium. So if you want to check whether their endometrium is functioning or not, you will have to give estrogen and progesterone. Numerous etiologies of this low FSH-LH have been found. Many of them are like neoplasia of the hypothalamus or the anterior pituitary. I told you Sheehan syndrome, drugs, radiation, chemotherapy, and most common where pituitary fails to occur is single gene disorders have the hypothalamo-preoptic area peptides, hypothalamic GnRH production or FSH-LH. The genes required for their productions are defective. So hypogonadotrophic hypogonadism is a very small percentage of patients where FSH-LH is low, less than 1 MIU. It may be they may present with primary or secondary amenorrhea. They may even present with absent puberty. Often the absent puberty patients have single gene disorders of the HPO axis, mostly the hypothalamo-pituitary areas. So investigations are FSH, which is usually less than 1. At an early age, their AMH is normal. E2 is usually less than 20 picogram. Often puberty changes are not seen in those who present with primary amenorrhea, or they may present with primary or secondary amenorrhea if the pituitary is destroyed later in life. So how do we treat them? We know that in this whole axis, we can produce estrogen, we can produce progesterone, all cells are good, except that the pituitary is not producing FSH and LH. So we can treat them with a GnRH pump, which is inserted under the skin and goes on releasing GnRH, just like the GnRH which is coming from the pituitary. Or we can treat them with injections of gonadotrophin. Now, we as gynecologists prefer to use injections of gonadotrophins, whereas the GnRH pump is usually used by endocrinologists when young girls come to them with delayed puberty. So injections of gonadotrophin, usually we have to give both FSH and LH. And we have to give the dose according to their body mass index at least for 10 days and monitor with transvaginal ultrasound and serum estradiol level. Once the follicles reach 20 mm, we have to give the LH surrogate, that is human chorionic gonadotrophin. And we also have to give corpus luteum support because their pituitaries are not producing LH. So corpus luteum will die as early as after the effect of HCG goes. So we have to give them injection of HCG to support the corpus luteum, at least 1500 IU on day 6, 9, and 12 post-rupturing dose of HCG 10,000 or daily progesterone and estradiol till a pregnancy test is confirmed and 2 weeks after that, till the placenta takes up. Now this is WHO class or type 1 anovulation is very successfully treated with gonadotrophins. almost equal ovulation and pregnancy rates are seen, that is as high as 90%. So it is a very, very rewarding treatment. Don't get scared when you get a hypothalamo or a hypogonadotrophic hypogonadism patient. She will always be thanking you all her life for giving her a pregnancy, and it is really simple. Mostly they don't land in any complications. Hyperstimulation may be there when too many follicles are growing, but you cannot give Lupride or GnRH for the rupture of follicles. Now, group 2. I told you that in these patients, the HPO axis is intact. 85% of anovulatory patients fall in WHO group 2. They often have normal levels of FSH, normal to elevated LH, but the ovaries do not respond appropriately. Thus, no dominant follicle is established. WHO group 2 could be due to etiologies which include polycystic ovarian syndrome, congenital adrenal hyperplasia, abnormal FSH-LH receptors, and certain medications taken by the patients. PCO is most commonly encountered condition in this group and is defined by excessive ovarian androgen production, oligoamenorrhea, and polycystic ovaries on ultrasound. The high levels of androgen in PCOS facilitate recruitment of multiple follicles. We know that androgen is a substance which prevents atresia in the ovary. The preantral and the secondary follicles do not undergo atresia when intra-ovarian androgens are high, and that is what happens in polycystic ovarian patients. So PCOS facilitates the recruitment of multiple follicles, but never reaches the FSH window. Thus, no dominant follicle is produced, nor does estrogen reach the appropriate threshold to stimulate a LH surge. So estrogen never goes to 250 picogram. It keeps shunting between 60 to 80 picograms in the blood. Now we finish. The class 3 are the patients who do not have follicles left in their ovaries, and usually they will not respond to any ovulation induction treatment. In the recent years, a lot of things are being done to, they say that the primordial follicles are always there, but some hypo signals are lacking, and that is why they are not becoming primary, secondary, preantral. So now they are doing some stem cell therapy, or they are removing the surface, cortex of the ovary and then putting some transcription factors on them, and then again putting them back on the surface of the ovary. That is rejuvenation of the ovaries. All these experimental things are being done, but yet nothing has come into day-to-day practice. And success rate of most of these patients with poor ovarian reserves or absent ovarian reserves or very low AMH, less than 0.5, they do not respond to majority of the ovulation induction treatment. Even growth hormone has been tried with very little success rate. Now, let us look at our PCO patients. In short, these are well estrogenized patients. They have more than 20 follicles of 2 to 8 mm in subcortical follicles. They often show, the ovary on transvaginal ultrasound often shows hyperthecosis. If we do a serum testosterone, levels are quite high, and patients are often anovulatory, and therefore they have irregular menstrual cycle. So the hypothalamo-pituitary ovarian axis is deranged due to chronic low levels of estrogen in the blood that inhibits the rise in FSH and prevents the dominance of a single follicle. The principle of treating PCO patients, we know that chronic estrogen, which is there, and it is not allowing the FSH also to increase. Estrogen levels are not increasing. FSH is neither decreasing nor increasing. All follicles are sitting at the same place. So what we want the hypothalamus and pituitary, we want to cheat them by blocking the estrogen receptors. As soon as the estrogen receptors are blocked or estrogen production is temporarily stopped, the hypothalamus GnRH pulses are going to rise and FSH levels are going to rise. When FSH increases, the follicles start growing. Multiple follicles which have got FSH receptors will start growing, and they will grow to have more and more LH receptors, and finally they will rupture with a LH surge because estradiol levels will start rising. Besides that, these patients also have higher circulating testosterone and insulin, which adds to the theca cell proliferation, and theca cell proliferation further adds to the testosterone. So the main objects of treating PCO patients is reduce circulating E2, reduce androgens, and reduce insulin. So that can also be done by reducing weight and lifestyle management. And the first drug, we are using it for more than 50 to 60 years now, is clomiphene citrate. It is a selective estrogen receptor modulator that blocks estrogen receptors in the preoptic area of the brain, pituitary, and endometrium. So what the text says is that mechanism and clinical outcome of clomiphene citrate, that is, it is a selective estrogen receptor modulator. It has been the first line of treatment in anovulatory oligomenorrhea for more than 40 years. CC competes with endogenous estrogen receptors in the hypothalamus and pituitary, interfering with the negative feedback signal of natural estrogen. Compared to natural estrogen, CC binds in the hypothalamus CC has a very long half-life. And so what happens, the FSH pulses remain high for a very long time and they are very strong. Therefore, clomiphene, those patients who respond to clomiphene, they will often have multiple follicles growing, 5 follicles, 6 follicles. And so chances of mild hyperstimulation and multiple pregnancies are very high when we use clomiphene citrate in patients of PCO. So usually we administer around 50 milligrams of PCO as a starting, as of clomiphene as a starting dose. If that doesn't give us any response, we increase it. That is known as a stair-step protocol. We increase it to 100 milligrams. Usually ovulation takes place exactly on 7th day of the last tablet of clomiphene citrate. And if patients fail to respond, then we use the other drugs which are effective in stopping the production of estrogen. So initial dose is 50, beginning, it may be started on 2nd or even on the 3rd day. The usual side effects are mood swings, hot flushes, diplopia, and photophobia. Another SERM, that is tamoxifen. The advantage of that SERM is that it doesn't have a negative effect on the endometrium. In fact, it causes polypoidal endometrium, and so can be used if CC shows a very thin endometrium in spite of ovulation. The ovulation rate with CC in PCO patient is as high as 80%, but the pregnancy rate is just 20%. It could be due to the anti-estrogenic effects on the endometrium. Multiple pregnancy and mild ovarian hyperstimulation are the side effects. Okay. In the absence of effect, we advise use of metformin or aromatase inhibitors, PCO drilling, or gonadotropin in patients with polycystic ovarian disease if they fail to respond to clomiphene citrate. So aromatase inhibitors. See, many times there was a lot of controversy about aromatase inhibitors, but these are excellent drugs. They have a lot of advantage, and maybe they may be called as the first line in PCO patients instead of clomiphene citrate because they have a very short half-life. They block aromatase enzyme just for 24 hours as long as they are being given. And after 24 hours, the aromatase enzyme resumes its activity. So when given from the 2nd to 7th day of cycle, temporarily no estrogen is produced by the ovary. And when there is no estrogen in the blood, or the falling levels of estrogen in the blood causes GnRH pulses to increase and increase the FSH levels. So it's not as strong or as long acting as clomiphene citrate. And often only 1 or 2 follicles will grow with aromatase inhibitors. So that is the advantage, that hyperstimulation and multiple pregnancies are much less with aromatase inhibitors as compared to clomiphene citrate, and there is no negative effect on the endometrium. So it is administered in the same way as clomiphene citrate, but the dose is 2.5 milligrams, may be increased to as high as 7.5 milligrams. Now, in some patients who do not respond to either aromatase inhibitors or clomiphene, metformin can be added. Metformin is a biguanide. It is an anti-hyperglycemic agent, often prescribed in type 2 diabetes. It decreases the circulating insulin levels by reducing hepatic gluconeogenesis and enhances the body's ability to excrete insulin through the gastrointestinal tract and peripheral uptake. Insulin resistance is common in PCO patients, and elevated insulin levels has a negative impact on ovulation by stimulating androgen production, decreasing decreasing sex hormone binding globulins, and increasing insulin-like growth factor, increasing the androgens in the ovary. So administration, usually the dose is 1500 milligram, but many patients do not tolerate. So we can start gradually 500 milligrams to start with and increase by 500 every week till you achieve the 1500 milligram dose. Addition of B12 with metformin is advisable to prevent the side effect of B12 deficiency in metformin patients. Now gonadotrophins. When we do not get response with metformin along with aromatase inhibitors and clomiphene citrate in PCO patients or in hypogonadotrophic hypogonadism patients, gonadotrophins are used. Now, previously, gonadotrophins came from animals. After that, they came from urine of postmenopausal women, which was separated by chromatography. Then we got the genetic engineering technique by using the Chinese hamster cell lines, and they're genetically, by altering the, putting a DNA segment that could produce FSH and LH, we started producing recombinant FSH. And now we have many biosimilars of recombinant FSH. I told you these are glycoprotein hormones, and the number of the carbohydrate molecules attached to these alpha and beta chain defines their half-life. So today we have one injection of FSH which lasts for 7 days, that is corifoliatropin. And maybe shortly we may also get an oral FSH molecule. So all these will help us in treating our anovulatory patients. See, by using anti-estrogens in PCO, we improved their own, increase their own FSH levels coming out from their pituitary. But if this doesn't, if it is not effective, then we add FSH from outside. Now, type 1 patients we know will respond only and only to gonadotrophins and not to any estrogens. But the type 2 patients, that is the PCO type patients, these are here the gonadotrophin use is the last thing, and it should be used only by people who have a lot of experience in the use of gonadotrophins. ASRM recommends the use of gonadotrophins only to be taken by those with appropriate training and experience. Gonadotrophin therapy produces favorable pregnancy outcomes with reported ovulatory rates of 70 to 72% in PCOS, and only 15 to 30% is the live birth per cycle. Now, if we are only inducing ovulation, then we should use FSH very, very carefully. So the very low dose as 37.5 to start with. Now we have these pens, so we can adjust the doses, and very, very gradually we go on adding FSH to that patient, increasing it every 7 days. 35, this is known as a modified step up, very low dose protocol. For 7 days, 37.5 IU is given intramuscular. Then you check by ultrasound if any follicle is growing or if E2 levels are rising. Again, increase it by 37.5 for another 7 days. Then check on ultrasound, look at the estradiol level. And when the follicles become single, 1 or 2 follicles will grow in this way. And when estradiol levels per follicle is above 250 picogram, you can give a trigger. If there are too many follicles growing, you have to cancel the cycle, but this does not happen in the step-up protocol. The other protocol is the step-down protocol, where you start with higher doses and gradually decrease. This in step-down protocol, usually there are a lot of follicles growing in PCO patients and may lead to cycle cancellation. Nowadays, with everyone having IVF labs around, if too many follicles grow with gonadotrophins in patients of PCOS, if you call them on the 4th or 5th day and you see that there are 13 to 14 follicles each side of 10 to 12 or 13 mm, you can put them or just convert them into an antagonist protocol, add citrorelics along with your gonadotrophin, and tell the patient that the best thing for them would be to go for an IVF freeze-all and transfer in a next natural cycle, that is cycle segmentation, in order to prevent chances of dangerous ovarian hyperstimulation syndrome or multiple pregnancies. So hyperstimulation rate has been as high as 68% in step-down protocol. So do not use a step-down protocol unless patient is ready for conversion into a IVF cycle. Otherwise, just cancel the cycle. Don't give any HCG. Culprit of ovarian stimulation is human chorionic gonadotrophin, not gonadotrophins by themselves, not FSH-LH. It is HCG. So if too many follicles have grown, patient is not ready to go for a IVF cycle, it is best not to give her anything. I would not even advise you to give a Gnrh agonist for rupture. Now, what is Gnrh agonist? We never discussed that. It is like Gnrh, but it has got a much longer half-life and much strong affinity for the Gnrh receptor on the pituitary cells. So it causes a surge of LH. Now that we get LH for rupture of the follicle, the follicles will rupture. We may do an IUI or a planned relation. And there should not be ovarian hyperstimulation in these patients. Initially, the primary ovarian hyperstimulation is not there. But if the patient becomes pregnant, HCG production starts and secondary hyperstimulation can occur. So whenever many follicles, that 15 to 20 follicles are growing on either side and patient is not ready to get converted into IVF, best is to cancel the cycle. So despite positive results associated with Gnrh administration, they are reserved for second or third line in anovulatory patients. Do not use them as a first line treatment. The other thing we can go ahead is with laparoscopic ovarian drilling. Now the advantage, I would always like to do a laparoscopic ovarian drilling before going for gonadotrophin, because you check the tubes, that the tubes are patent, that there is no other pathology like minor endometriosis or pelvic infection. And you also do a drilling of the ovaries that reduces or removes the testosterone or androgens from the ovary, it reduces the theca cell mass, causes spontaneous ovulation or increases the sensitivity to clomiphene citrate and letrozole. So it is better to do a laparoscopic ovarian drilling and follow up the patient rather than jumping on gonadotrophins for patients who are not intending to go ahead with IVF. So live birth rate with it is as high as 24 to 44%. Mostly when we are inducing ovulation, either with clomiphene, aromatase inhibitors or gonadotrophins, the best way to follow up these patients is with a transvaginal ultrasound. Nowadays, not much hormonal tests are done. Not even when we are doing IVF, we do not regularly do estradiol levels. We only do a progesterone prior to rupture. And most of the monitoring of follicular growth can be easily done by a transvaginal ultrasound. So now this is usually in our practice, we induce ovulation in anovulatory ovaries, and we know anovulatory can be type 1, 2 or 3, which we just discussed. But sometimes we have patients of unexplained infertility, mild male factor or minimal endometriosis, where we want to just hyperstimulate the ovaries and do an IUI to increase the chances of pregnancy. So in these patients also, clomiphene citrate along with some amount of gonadotrophin can be used. Now I am going to discuss some of the protocols for which we use in IVF. What is the difference in the protocols that we use for IVF or IUI is, we do use gonadotrophins in both of them. We may use only clomiphene citrate in IUI patients, but if we are using gonadotrophins, we do not use agonist or antagonist because we are not bothered about when the LH surge will occur. We check the urine for LH surge. We look at the ultrasound picture of the ovarian size. We can ourselves give human chorionic gonadotrophin for rupture and do an IUI. But that is not the case in IVF. In IVF, we want a lot of follicles to grow, the entire cohort to grow, and at the same time, we do not want the pituitary to produce a spontaneous LH surge. So while we are using gonadotrophins for the growth of follicles, we are using certain drugs like Gnrh agonist, antagonist, or progesterone to prevent a spontaneous LH surge. Now, I said progesterone because we know that in the luteal phase, FSH does not increase, follicles do not grow. So progesterone can be used as a drug for preventing LH surge. And in which patients can we use them? We can use them in those patients where we are not going to transfer embryos in the same cycle, or in donors where we are not going to use their endometrium for embryo transfer. Otherwise, For own IVF, where embryo transfer is going to be done, we can use agonist or antagonist. In short, I can just tell you what these agonist and antagonist protocols are. What happens is we start with gonadotrophin stimulation from second or third day of the cycle. And for 4 to 5 days, FSH injections are given depending upon the weight of the patient. And when the follicles become 13, 14 millimeters, that time we do not want a spontaneous LH surge, so we use a GnRH antagonist, either ganirelix or citrorelix. Now, what are these antagonists? They go and sit on the pituitary GnRH receptor and they just shut the doors of pituitary. Pituitary has a lot of FSH-LH, but that cannot come out in the blood. So they block the pituitary release of FSH and LH. So we continue with gonadotrophin and spontaneous LH surge does not occur till our follicles become 20 mm, and we bring about an LH surge around the day of, around the size, when the follicle size becomes 20 to 22 millimeters. Then previously we never had an antagonist. We had an agonist. They tried producing antagonists, but the antagonists which were in trial before used to produce severe histamine-like reaction. So they were out of market. And in the 90s, the only drug we had to prevent LH surge was GnRH agonist. And in the agonist, we start down-regulating 8 to 10 days prior to patient's menstrual cycle. So what happens, all the FSH-LH is released from the pituitary. The pituitary is exhausted. It has no FSH-LH. And after she becomes hypogonadotrophic, we start stimulating the ovary. We continue half the dose of our GnRH agonist. And once the follicle becomes 20 millimeters, which happens in 10 days to 11 days, a rupturing HCG is given. The only problem with the long protocol is if it is a PCO patient and we have completely have no LH in her pituitary, we cannot give a agonist trigger. We have to give a HCG trigger, and the patient can land in dangerous ovarian hyperstimulation syndrome if 20 follicles are growing on either side. So this is the progesterone prime. I told you that progesterone drugs, it inhibits GnRH pulses, and therefore the ovary doesn't understand progesterone. Ovary has receptors only for FSH-LH. So if you give gonadotrophins, follicles are going to grow. And if you give progesterone tablet to the patient, LH surge will not occur. So follicles will grow, LH surge will not occur, and a rupturing HCG given will cause the second maturation or rupture of the follicles, or we can aspirate them in 36 hours after HCG. Now there is one more concept, that is, there are follicular waves, We have cancer patients coming to us for, freezing of their eggs, and there is very little time. They want to get chemotherapy, radiotherapy started as early as possible. So we don't wait for second day of their cycle to start their stimulation. The ovary has got, a cohort of follicles increasing, coming on the surface every now and then. And as soon as whatever is one, even if one follicle is growing and you see many small follicles in the ovary, you can start stimulation at that time. This is known as anytime stimulation, which is often done when we have no time to start stimulation, or in donors where we have a cohort of follicles. Now what will happen? Some follicle which is growing may just rupture and start producing progesterone. It doesn't matter. Our other follicles keep growing with gonadotrophins, and we can give them the rupturing dose of HCG whenever we want to. So this is a concept of anytime start or ovarian follicular waves, which keep coming up every now and then. So I think there is a lot more to talk about gonadotrophins and stimulation. I have tried my level best to complete the topic in the, over time. But if there are any questions, you can please put forth.
Thank you, ma'am. I would request Dr. Shivani, ma'am, to give her concluding remarks. Over to you, ma'am. Hello, am I audible?
Yes, ma'am, you are audible, ma'am.
Yeah.
Shivani, ma'am. Ma'am, Rajguru, sir.
Rajguru.
Okay. I would request Dr. Adinath Rajguru to give his concluding remarks. Over to you, sir.
Thank you. Good evening, friends. Dr. Manju Jilla ma'am is a senior IVF consultant. Really, you taught very nicely the recent updates on the ovulation stimulation protocols. Surely it will be helpful to the all ERT consultants to update themselves. Ma'am, can you enlighten some protocols in the poor responders, those who are having the very low ovarian reserves for the IVF?
Correct. I told you that there are the concept of menopause, that primordial follicles are over, is now an old concept. That menopause occurs because certain transcription factors inside the ovary are lacking, and the androgens inside the ovary are decreasing. So there is a concept of giving androgens which increase the number of antral follicles coming to the surface.
Okay.
And whatever it is even if we have lower number of follicles in certain patients, it is the age that determines the success. So if you have a patient who is about 29 or 30 years old with an AMH of 0.5, and even if you get 3 follicles by stimulating her with FSH, and of course they need LH also, these patients, you will get a much higher pregnancy rate than a 40-year-old patient with an AMH of 3. The stimulation protocol can be agonist or antagonist, but always nice to use androgel and coenzyme Q10. In my practice, I use them and I really get good results. And I don't care, even if I get 2 eggs, I don't bother. That's a wonderful success rate is there, provided a patient's age is less. If age is high, whatever you do, you are going to fail. You can use any protocol, agonist or antagonist, and continue with CoQ10 because it improves the mitochondria inside the oocyte.
Thank you. Really, it was very nice discussion. Thank you, Dr. Pardesh sir and Ajay, for giving me this opportunity. Actually, I was not feeling well. That's why I joined late. Thank you once again. Thank you.
Thank you, Dr. Rajguru. Actually, Dr. Rajguru is not feeling well, but still, I wanted to, he wanted to attend Dr. Manju Jilla's talk. I said, no, doctor, you take rest, but he joined.
Thank you, Manju madam. And thank you, Adinath.
Thank you,
sir, for there.
Dr. Ajay,
now we have got a guest of, special guest with us, Dr. Nandita Prashitkar, who is my elder sister and president of AMOGS and ex-president of Foxy. I welcome Nandita ma'am and request her for the questions.
Thank you. Thank you. Thank you, Ajay. Thank you so much for inviting me into the program. I was listening very nicely to the seminar. Once in a while, it's nice to be a panel delegate. And Manju, very nice talk you gave. I really enjoyed it. And just wanted to, I came in to request all of you all. I have worked a lot in Foxy, done a lot of activities and worked in women's health, policy making and all with the government. And I really wish to take it to a different level. I wish to work on the international field also. So I am requesting for your support in my next endeavor. I wish to go for Foxy representative to FIGO, and I request the support of all my friends and all of my colleagues. So I would really be happy if you would support me and vote for me in this endeavor. So sorry for interrupting you all, but really it was a very enjoyable seminar. And thank you, Dr. Pardesi. Thank you, Ajay. Ajay, all the best to you too. And I'm sure it will go very well. You are very well suited for the position. And I hope and pray that we all are there together. Thank you. Thank you very much.
I must commend that Nandita has always worked with people, for people, and she is the person who should be, voted for representation in FIGO, because she is really suitable for that. She can, represent our country So I wish you all the best, Nandita.
Thank you,
Thank you so much.
Dr. Thank you, Dr. Nandita man. I agree with Dr. Achala Batra man. As Dr. Nandita Palsetkar, her successful tenure as Foxy President, AMOX, and all other organizations also. Now it's our turn to elect her as a FIGO representative and see her on platform of FIGO. Thank you. We wish every success to Dr. Nandita Palsetkar. Thank you, madam. Thank you.
Thank you.
All the best, Anita ma'am. All the best.
Thank you, Vinita.
Yes, Nandita madam, we are delighted to have her because she is one of the most successful IVF specialists of India. Thank you, Nandita ma'am. Thank you, and thank you, Manju ma'am. It was very in detail. It was a PG thesis, likewise on ovulation stimulation protocol. Very detailed and very thorough knowledge. Thank you, madam. Thank you very much. Over to you, Karishma.
Yes, thank you, sir. Moving on, I would like to introduce and invite Dr. Mandar Karambadekar and Dr. Yashwant Pawar to chair the session as chairperson. So, yeah, thank you. Yes, sir.
Pawar sir has not joined, I think.
Okay.
Okay, Mandar sir. Yeah, Mandar sir is there.
Okay. So Mandar sir is Secretary Chalisgaon OBGY Society, Director Shalya Shobha Stree Arogya Bhavan and IVF Center Chalisgaon District Jalgaon. Dr. Yashwant Pawar is President Chalisgaon OBGY Society, Director Mauli Hospital Lakshminagar Chalisgaon Jalgaon. I would request Dr. Mandar to introduce and invite Dr. Ajay Mane to talk on medical legal issues in the infertility practice. Over to you, sir.
First of all, I wish all the best and to the Mane sir for his candidature for Vice President West Zone Foxy. Sir has been member.
Mandar sir, we can skip the introduction. You can speak as an opening remark. Yeah.
Yeah, Mane sir is well known to everybody, and he has organized this nice informative session for all of us. So I hand over my mic to Mane sir to start with his presentation.
Thank you. Thank you. Thank you, Mukund sir. Sorry, Mandar sir. We are used to say that Mukund sir is his father. He's very fatherly figure for all of us. Thank you very much, Chalisgaon OBGYN Society. I'll go very fast because we have seen so much of the aspect of this law since 25th of January, and we have heard so much of things. We have discussed all the things, and after discussing with Shivani also, and I took an opinion of High Court advocate from Aurangabad today only after the discussion, and I am very much thankful to Shivani madam, then our president Shanta ma'am, Madhuri ma'am, all ISAR president and IFS office bearers to have gone to the minister and secretary to clarify the implementation strategies, all the things, and they have been granted. And with the RTI later, we came to know that we are having 6 months period, and within that, as Shivani said, at the end of March, we'll be getting the all registration facility and everything. So it is very much clear now. Okay, fine. We'll go for the lecture basically, and my gratitude to Achala Batra ma'am, Asharao ma'am, Rajeshri Palladi madam, Vinda Singh ma'am, Rajan Singh Pardis sir, then Yashwant Pawar sir and Mandar Karambadekar sir. Chalisgaon Society, my co-speaker, the great personalities, Rishikesh Pai sir, Dr. Manju Jilla ma'am, and Vikram Lokhande, and chairperson Shivani Sachdev, great warrior from Delhi, then Dr. Ajanath Rajguru, again a great warrior from Usmanabad, and Dr. Minal Chidgupkar, great warrior, IVF specialist from Solapur, and Dr. Stalin and Child Healthcare. Okay, history of ART bill, I'm not going into detail. Since 1995, one committee was formed by the consultant and told to government that some bad practices are going there, and then they formed 20th April 2001 ICMR formed a committee regulatory ART practices. 2004 national guidelines came, 2008 ART formulated, and in Gazette published on 25th of January. That is the end of the history. ART status, I'm not going to detail. Authority, national board, state board, all the things. National board, within 90 days of the board shall be formed. As she told, before 31st March, they will be forming the national boards, and the powers, the duties of national boards: policy matters, monitoring, implementation, code of conduct, and overseeing various bodies. Registration, see, is one in previous bill. They have mentioned that there should not be any requirement for the PCP entity registration separately, but they have not mentioned here. Maybe they will be making it clear. But as I assume the law, there must be two registration: one with ART clinic and one with the PCP entity registration. Okay, both registrations are different. Fees will be maybe same. In PCP entity, if you are having sonography center plus ART clinic, it is 35,000 for fresh registration, and 50% 17,500 for the renewal after each 5 years. Okay. Then boards and everything, boards will be formed in 90 days. Within 60 days, you have to apply and get the process. And if within 1 month, they should not, they shall give you the registration. If they do not give you registration, they should give a registration after hearing your explanation. That is the best thing they have done in this law. The person is asked for the explanation for the rejection, and they are made liable for that, the approved authorities. Certificate of registration must be displayed. Then rejection, I told you, appeal within 30 days to the state board, and against state board is state government. Okay. Owner change, we have to re-register if the owner is changed. Then validity is 5 years. For surrogacy, it is 3 years. Okay. ART clinic 5 years. PCP entity 5 years. MTP lifelong. No renewal of MTP. Renewal, as usual with PCP entity, likewise 60 days prior we have to give the letter. This is RTI letter which explains everything, and I'll read the provided that such clinics and banks shall see the conduct any such counseling or procedures and blah 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 blah. We are not going to into the details. So they have given us this provision clearly mentions that the clinics and the banks may continue such procedures for 6 months from the date of commencement of the act, that is the 25th of January. So it is clear now. What are the forms? Form A, A1, A2, they are in previous bills. New rules and regulations may give the numbers, and the name nomenclature may be different, but even they will be like this. A is application, A1 is for application for ART bank, A2 is for research center, then B certificate of registration, C is a rejection as if it is there in PCP entity. D is consent for the couple of IVF ICSI, then from E consent of artificial insemination, F is consent of artificial insemination with the donor semen. Then G is consent for freezing of embryo. G is for invasive in PCP entity. Okay. From H is surgical extraction of sperm. I, J, K, all the long list of these forms. Okay, I'm not going into the detail. Types of ART clinic, it was given in bill, so it is not yet clear that level 1, level 2, level 3 will be there or not, but must be they will be giving most probably level 1. OBGYN hospital clinic can perform without registration, limited scope, only counseling center and general obstetrician can be there. Types of ART clinic, level 2 and level 3 needs registration. What is level 2? Then IUI facility, assessment, TVS, transvaginal facilities, all the things they are in level 2. And level 3 actually ART procedures, ICSI, MC, everything. Freezing of sperms shall be quarantined for 6 months. Tested for HIV, hepatitis B, C. One donor may donate for one recipient. Old provision was there. One donor can give for 10 pregnancies. And before that, it was 27, but they came with the bill with 10 pregnancies, and now they have given that one donor may donate for one recipient only. Very difficult. Then relatives and near friend oocyte sperms are not allowed in ART. As Shivani said, we should not bring the donor, but in surrogacy, we should bring the surrogate mother. This is the main difference between these two laws. Embryo transfer, maximum 3 are allowed to transfer. Many are courageous to transfer only one single embryo transfer, and they say that it is of good results. ART 22, right of a child born through ART deemed to be a biological child of the commissioning couple and will be entitled to for the rights and privileges available to a natural child. Means usko sab estate जायदाद पूरी मिल जाएगी. Okay. Donor bank male, semen donor woman, 21 year to 55 years, and commission couple, it is a 21 year to 55 years and a woman of 21 year to 50 years. As Shivani said, after 45 years, the results are very bad. Okay, shall be given at one commission couple only. Okay, shall not mix semen from more than one donor. Two donors semen cannot be mixed. It is a punishable act. Shall be preserved for max up to 10 years. Then shall be given to the research institute or destroyed with the permission of the couple. Okay, donor bank female. Oocyte must be taken from 23 years to 35 years. That is the basic we consider best obstetric years. Recipient woman must be 21 to 50 years. Then oocyte donor must be married woman having at least one live child or more than 3 years. So commercial surrogacy is and the commercial donor, they are not allowed here because many of the instances we have seen that. At the time, only up to 7 oocytes at once in a life. Then she can give only 7 oocytes or retrieval of 7 oocytes at one time. But the attempts are not mentioned. How many attempts can be done on one woman for the same woman? Once in a lifetime for a same woman can be given, but attempts are not mentioned. Maybe 3 in previous bill they have given. Shall be given at one commission couple only. Shall be preserved for max up to 10 years. Same thing. Okay. Transportation prohibited. Sale prohibited. And transportation out of India is not allowed in the permission of appropriate authority for own purpose is allowed. Okay. Then record keeping, all records must be maintained as prescribed. Online submission of records maintained for 10 years on expiry to be transferred to national registry and records to be available for inspection. In surrogacy, it is a 25 years record maintenance. Okay. Prohibited actions, abandon, exploit of the born child or the commissioned couple, import such material, sell such tissue, use of intermediates, getting embryo gametes, dalal type lobe, and transfer embryo into male or animal is not allowed. That is punishable act. What is offense? It is a cognizable. Means what do you mean by cognizable? A police officer may inquire on his own. He did not have an order from magistrate. That is a cognizable. The police say NC and cognizable. NC means non-cognizable. They need order from magistrate, but this is cognizable. Police officer can come and start investigation and arrest without warrant. And bailable. What do you mean by bailable? Bail, you get the bail at police chowki only. If it is non-bailable, the bail will be given by the JMFC or the magistrate, but you need to be behind bar in the police station till that moment they present you to the magistrate. So this is bailable, means you will get the bail in chowki only. It is a judicial magistrate first class, not less than that. Fine up to 5 lakhs to 10 lakhs for first time, and subsequently, if done again, then imprisonment of 8 to 12 years with fine of 10 to 20 lakhs. Okay. Advertisement regarding the facilities of sex selection ART offenses, then they have given a 10 lakh to 25 lakhs of fine and imprisonment of 5 to 10 years. I have main provision, omission of removal of name on conviction is the most dangerous thing in our life. We cannot practice after that. Okay. Then surrogacy. I'm not going into the detail. The bill has already passed, gazetted. Criteria for a surrogate mother. Be at least 25 years old and younger than 35 years. Healthy BMI as determined by your doctor. Have carried at least one pregnancy successfully to term. Be raising a child of your own in your own home. Experience होना चाहिए उसको, ठीक है? No gamete of surrogate is to be used, or no sperm from the surrogate husband is to be used. Only one time in her lifespan. Number of attempts not specified. I told you in old criteria, embryo transfer only for 3 times allowed. But now maybe in rules and regulation they may give this criteria. Surrogacy without own child. In most of the cases, no. You cannot become a surrogate without a previous pregnancy. And there they have given that there should be a 2 years gap between 3 years gap between your own pregnancy and the surrogacy. Any safe and secure surrogacy journey requires certain. Then she must not be close relative of the interested couple altruistic surrogacy only, as discussed by Jilla Madam and Shivani, that she must not be a close relative. Okay, it is clear now. She can be a willing woman, as Shivani said. Thank you, Shivani, for that information. And altruistic surrogacy means it is not a commercial surrogacy. Paise de do usko aur usko karo. No, it is a paropkar like such thing. Okay, I'll help you. Likewise, it is there. She must be married and having her own child more than 3 years. She must be between 25 to 35 years old. She has not done surrogacy before. Must have a certificate of medical and psychological fitness to perform surrogacy. Okay, there must be a gap of 2 years between pregnancy and surrogacy. In older criteria, embryo transfer only for 3 times allowed. Consent of spouse is mandatory if she is married. If she is widow, it is not mandatory. Then should not have received blood transfusion within 6 months is the second important thing in this criteria, and must be a Indian citizen. Okay, commercial surrogacy allowed in India in 2002. Banned for foreigners in 2015, surrogacy 2016 passed in houses, and now commercial surrogacy is banned and surrogacy is not allowed for foreigners. Then couple age must be Indian citizen, married female 23 to 50 years and male 26 to 55 years. Must be a married couple at least 5 years. Then and then only you can have a surrogacy. मेरे 5 साल प्रयत्न करो, उसके बाद नहीं हुआ तो फिर surrogacy करो. Should not have any child in ART, adoption, etc. So, इसमें एक exception is there. The mentally or physically challenged baby or untreatable conditions baby, if they are having, they are allowed for surrogacy. Okay, surrogate mother must be between 25 to 35 years old. The disparity is very much there. Basically, I don't understand the intending woman. The intending couple, they have given female 23 to 50. And intending woman, they have given 35 to 45. Why this gap of 23 years to 35 years in intending couple, intending woman? I don't understand, but the government can do anything they have given, so we have to accept. Other issues, I'm not going into detail. Percentage and surrogate miscarriage. Okay, if surrogate MTP, parentage and surrogate miscarriage, an infant born through a process of surrogacy will be considered as the biological child of the aspiring couple. The abortion of the surrogate child will require the written consent of the surrogate mother and the approval of the appropriate authority. Then and then only you can terminate the pregnancy. This is the difference. Okay, offenses and penalties. Then offense of 5 years imprisonment, fine of 5 lakh, and then subsequent act 10 years and 10 lakh. Record keeping 25 years. I told you. Take home message, follow all protocols, document well and accordingly. Consent is very, very, very important and must in all process. Keep trained and prescribe qualified staff, because if the qualified staff is not there, they are not going to register your center, and the qualification is given there. It must be a costly affair. So I'm sorry. Training and drills regularly with your staff, because they have to be very much on toes. Have a system in hospital working pattern. Keep good relation with the colleagues and help them when needed. And if needed, I am there always. Thank you. Thank you very much. Women empowerment in woman is always a mother in her life. She's carrying a baby, symbol of love, and carrying a gun for her protection. And this is our woman empowerment in India. Dr. Captain Deepashika Chetri, salute to the woman as she is carrying gun for the nation and carrying a stethoscope for the unit and for her colleagues. So salute to this woman captain, and salute to the greatest army of the world, that is Indian Army. And salute to these, the last chain of the health service in India. Almost around 170 crore people they have immunized once and 65 crores twice. See at which place she is going. See, she is carrying a baby of 5 months, vaccine carrier, the kids, husband, and sitting in the run. So salute to this woman. And again, I request you to kindly vote for me for the post of Vice President, West Zone Foxy. There are 2 posts, so kindly vote for me once, and second is your choice. Thank you. Thank you very much. When they can be together, why can't we? So stay together, help your colleagues. Thank you. Thank you.
Thank you so much, sir. Now I would request Dr. Yashwant Pawar, sir, to give his concluding remarks. Over to you, sir.
Pawar, sir, are you there?
Yeah, yes.
No.
Sir.
Mandar, sir.
Okay, Mandar sir. I would request Mandar sir to give his concluding remarks. Over to you, sir.
Yes, I think there would be a need of another session to explain all these laws in details. However, sir has covered very nicely, and it was really eye-opener for us who have not gone through the material as of now. And it seems that sir would be helpful in future also, that he has told us. And thank you for a very nice session. And conclude my piece.
Thank you. I can see the Yashwant Pawar sir has come, I think.
Karambalkar sir is there, Mukund Kambalkar. Let him invite Dr. Karambalkar. Ajay.
Mukund sir आलेत का? मंदार दादा, पिताश्री आलेत का?
हो, म्हणजे मी हॉस्पिटलला आहे, बाबा घरी आहे. बोलतो.
नाही, ते नुसतं लॉग इन केलं वाटतं सरांनी.
नाही,
ओके फाईन. नाही, ओके फाईन. विल मूव फॉरवर्ड. सर आले की सरांचे आशीर्वाद घेऊया. नेक्स्ट.
Moving on, I will invite and introduce Dr. Ajay Mane and Dr. Manju Jilla to chair the session as chairperson. And I would, yeah, we have already.
Next. Rishikesh sir alele hai, so we'll take Rishikesh sir's lecture there.
Yes.
Next.
Yeah, I'll welcome him.
Yes, I would request Dr. Ajay Mane to introduce and invite Dr. Rishikesh Pai sir to
next
talk
slide,
on.
please.
Stalin, next slide. Doctor, next.
Stalin. Go ahead.
Move on to Dr. Rishikesh Pai sir's CV, please.
Yes. Go. Yes. No. Come back.
Thank you.
Rishikesh Pai sir. So much of his CV. He's the incoming president of FOXY, basically President Indian Association of Gynecological Endoscopy 2007 to 9, President of Mumbai Obstetric Gynecology Society 2008-9, Vice President Indian Society of Assisted Reproduction 8 to 10, Assistant Honorary Consultant K. Bhabha Municipal General Hospital from 1991 till date, Consultant Gynecologist Leelavati Hospital and Research Center Mumbai, Consultant Gynecologist Fortis Sleafham Hospital New Delhi, then Adjunct Associate Professor in Clinical Embryology and Andrology, Virginia, Norfolk, USA. Treasurer of the FOXY 2009, then Senior Vice President FOXY 2006, Assistant Honorary Professor D.Y. Patil Medical College, Mumbai University since 14 years. He is a postgraduate teacher in gynecology at the DNB Examinations, National Board of New Delhi. I failed once there in DNB exam, very tough examination. Academic first, Dr. Pai is one of the leading pioneers. I'm very much happy to read this. He is a leading pioneer in the field of infertility treatment. He has been the first doctor in India to introduce the following innovations. Introduced the assisted laser hatching, introduced the technique of spindle view, introduced the technique of ovarian tissue freezing, introduced the technique of oocyte freezing, introduced the technique of freezing embryo with the vitrification, and introduced the technique of metabolomics. So I welcome Dr. Rishikesh Pai sir, who is a very great personality academically and as a human being also, and I request him to proceed with his lecture. And he's a techno-savvy
Thank
person.
you. Thank you, Ajay. I'm actually in this thing, in Leelavati. Unfortunately, the mask is on. But first of all, let me wish you all the best for your vice presidentship. And you have been done a lot of contribution to the federation, and I hope gods will be kind to you, and the electorate will be also kind to you. Dr. Gnrh Singh Pardesi is also there. He will be he's our past vice president of FOXY, and he's also the president-elect of the AMOX. Very dynamic personality, and more than anything else, very good person, good human being. And then we have got a lot of my friends are there, Dr. Manju Jilla, and pardon me if I,
Sir, you got muted, sir.
Dr. Pardesi, will you share the presentation?
Pardesh, sir. Sir, Pardesh, sir, you are also muted.
Yes.
Presentation jara share kara.
Oh.
It's actually
yes.
Dr. Nandita, my colleague and the Dr. President of the AMOX. It is her presentation which I am also giving at present.
Is it visible?
Yeah,
Ajay?
yeah, it is visible.
Yes.
Sir, but it is not full screen.
Yes.
You
yes,
click
yes,
on the.
full screen.
नाही sir, नाही झाला आमच्याकडे.
Full screen.
From beginning ला click करा नाही.
This is beginning only from this slide.
नाही पण full screen नाही झालं sir.
Okay.
जरा खाली ना एक आयकॉन आहे बघा राईट साइडला डॉक्टर परदेशी.
68% च्या बाजूला. 68% च्या बाजूला खाली राईट लोअर कॉर्नर.
राईट लोअर.
तिकडे असं कप सारखं आहे बघा, कप सारखं.
68% च्या बाजूला. खाली आहे ना सर. तुमचं
remote
कर्सर
control.
मूव्ह होत नाहीये.
You can click on start a slideshow also.
Start the slideshow.
Yeah.
Where?
Left
There
ला
in the
ऊपर.
left corner.
Left corner.
From the beginning च्या खाली.
Okay, I will.
बंद करून परत चालू करा सर्व.
तसंच करतो कारण काय झालं.
हा ठीक आहे ना, पण मला फक्त थोडं वाचताना.
नाही सर तुम्हाला छोटं दिसेल. ऋषिकेश सर तुम्हाला छोटं दिसेल सर ते.
चालेल का? ओके.
नाही नको नको.
नाही ठीक आहे मी करतोय पुन्हा.
ते फोन.
ओके. Is it visible? Is it visible?
काहीतरी होत.
होईल आता.
होईल काहीतरी होतंय.
ठीक आहे, मी जरा एनलार्ज करतो आणि बोलतो. नो प्रॉब्लेम. तुम्ही आता नेक्स्ट. सो इफ यू लुक एट द इंडिकेशन्स ऑफ I just wanted to give a quick talk on what's new in ERT. So for that you need to know.
Is it visible? Is it
yeah,
visible?
yeah, it is visible. Hello. So
Okay.
can you hear me, Ajay?
Yes.
Yes sir, yes.
So what
Yes, sir.
basically we all know that there are two types of infertility: primary infertility and secondary infertility. Next slide, please. And we do basic investigation like semen analysis. I don't do mid-luteal progesterone, but if you want to know whether luteal phase is adequate, you can do a mid-luteal progesterone. Normally, you will do an HSG to see whether the tubes are open or not. But basic ultrasound nowadays, I do 3D ultrasound because uterine malformations cannot be diagnosed by 2D ultrasound. Ovarian reserve testing I do by AMH and AFC counts, and basic investigations I normally do prolactin, TSH, and I also do rubella antibody. Rubella negative, we first immunize the patient, and also do thalassemia because thalassemia is very prevalent in our country. Next slide, please. Next slide. So basically, what are the treatment options? One is simple ovulation induction. Many people do planned relations, and many people achieve pregnancy with that. Then those who don't become pregnant, we do IUI 2 to 3 cycles. And if that fails, then we go for IVF or ICSI. If the count is very low, we go for ICSI. If the count is normal, adequate, we do IVF. But nowadays, many people are doing ICSI for all. Then if there is very poor counts or where there is a very poor number of eggs or no eggs, for example, menopausal women, then we go for donor gametes, either donor sperm or donor egg. And ultimately, if the uterus is damaged, we would go for a surrogacy. Next slide. So if you look at IUI, basically we wash the sample and put it inside the uterine cavity. Next slide, please. And you all know that we do mild stimulation, and when the ovulation occurs, we can give a trigger to bring about ovulation. That time we wash the sperm, and best quality sperm we put inside the uterine cavity. Next slide. And these are the indications of IUI. Many people, like for example, in UK, they don't do IUI. Only they do it for donor insemination or if the husband is HIV positive. Normally in UK, they tell patients to try for 2 years time. If that fails, they directly go for IVF. Because that's for National Health Service. They feel that IUI is of no relevance. It's not that cost effective. But in our country, we still can do IUI because it's simple, and because it is simple and cost effective, we can give 2-3 cycles of IUI, and many patients do become pregnant with IUI. So IUI is very important for our country. Next slide. And these are the indications for IVF, such as blocked tubes, endometriosis, and a host of indications. Normally, if everything else fails, then we can do IUI, IVF. You understand? One second. So basically, if suppose what are the indications for ICSI? So in the advanced stage, then we do ICSI, where if the counts are less than 5 million, if there's failed fertilization with IVF, if there's azoospermia, we can take the sperm from the testes. So in pre-embryo genetic testing, we have to use single sperm for fertilization. There are many sperms which are attached to the zona following IVF. Then by mistake, when you are doing biopsy, you may take a sperm and genetic analysis will be done of the sperm instead of the blastomeres or the tropectoderm. So for patients who are undergoing PGD, you need to do ICSI. In oocyte freezing, frozen oocyte, when you thaw them, you have to do ICSI with them. So there are a lot of indications for ICSI. Next slide. And you can see that normally this is if the count is less than 10 million and very low count motility is there, or total motile sperm count is less than 1 million, you do ICSI. If the count is 1 to 10 million, you do IVF. And if the count is more than 10 million or post-wash count is about 5 million, you will do IUI. Next slide. So pre-RT therapy, before therapy, if there's a PCO patient, you will improve the BMI, change her lifestyle, try to get her weight down, put her on metformin and then stimulate her. If there's a hydrosulfing, you will try to tackle the hydrosulfing by removing it or disconnecting it or excising it. If there's a endometriosis, if it's a very large endometrium coming in the way, you will remove, decompress the endometrium. And if there's a fibroid, normally what I do in fibroid, I first do the IVF, freeze the embryo, then I go in. And if the fibroid is more than 4 centimeters or submucous, I will remove it by laparoscopy. After 3 months, we will do transfer. So I don't have to go into this IVF. You all know, Manju has also nicely talked about it. You stimulate the patient, monitor it, give ovulation trigger, do ovum pickup, and then do fertilize the eggs either by IVF or ICSI, and then do the embryo transfer. Next slide. So what are the new innovations now? So in ICSI, we can actually see the spindle, and we can, when I'm doing the ICSI, we can do the spindle view, and we can actually see where the chromosome spindle is, and then inject the sperm so that it doesn't damage the spindle. The second thing which we can do is use the IMSI, wherein we can magnify the sperm nearly 6,600 times. Normally in ICSI, the sperm magnification is 200 times. Here we magnify the image 6,600 times, so you can select better quality sperm. And there is also other innovations like embryoscope. Next slide. So these are the first. I don't want to get into this. Next slide. Can I have the So now in the sperm preparation technique, what are the new things that have come? One is that you can do swim up or you can do density gradient. Next slide. But there is a new technique. I don't think I've written it here, that we can also do what is known as microfluidics. So the latest technique that has come, which I've been using for the last 2 years, there's a cartridge and you can just load the sperm, and the best quality sperms are harvested using a microfluidics technology. And especially in those with poor sperm DNA fragmentation, very high sperm DNA, you can use microfluidics, and we are getting excellent results with it. So we do microfluidics, and following that we do IMSI, and then get the best sperm and do injection. Next slide. So this is how we do the stimulation in IUI, 2 cycles of clomiphene with FSH, and next slide. And if that fails, we can go for a pure gonadotropin stimulation. But normally, if we have to, I normally offer them now, this is known as advanced IVF. So I tell them that before we go for IVF, we can give, normally you can give HMG 150 unit on alternate day, 3, 5, 7, 9, 11. You can add an antagonist and then give the HCG or a GNR trigger and do IUI. So this is the advanced IUI. So before we go for, and when I do IUI, I use a proper high quality media, and I use a embryo transfer catheter instead of a IUI catheter to do IUI. And with this, we get 20% pregnancy rate. So this is also a very good way of before you jump to IVF. So this is controlled ovarian stimulation, which we do. Next slide. Next slide. So I think Manju has already told you, based on the AMH and AFC level, we use normally nowadays we use a gonadotropin plus antagonist cycle. Next slide. This is the antagonist protocol, which I'll not go through. Next slide. And these are the doses of gonadotropin. And if there is a lot of follicles, more than 15 follicles on the day of trigger, we nowadays give a GnRH trigger and then freeze the embryos and then transfer them in the next cycle. Next slide. We can also use mild stimulation protocols, especially now in India. A lot of people, in order to cut the cost down, are using mild stimulation protocols, but the results are not as good as a standard stimulation protocol. And nowadays, The gonadotropins that are available are easily available, very low cost. But I do my whole, if there's a poor patient or not well off patient, I can do a whole gonadotropin stimulation for as low as 10,000 rupees. In fact, many of my patients who are not well off, who are economically weak, below the poverty line, I can do an IVF cycle for 50,000 with medicine. So this, because I want to, we must help our poor people. But at the same time, I must caution you that we should not lower our prices. So if there's a middle class person and or a upper middle class, we should not do, we should help the people who are economically disadvantaged. There are 800 million of them. Those people, even you do free cycle, I don't mind. So we have to understand that for them, our commitment is to help them. But for the middle class, we can do a reasonable cycle. Next slide. So monitoring by ultrasound, next slide. And then pick, as I told you, we can do the pickup and give the trigger, next slide. And this is how we give trigger. If there is any danger of hyperstimulation, instead of giving a HCG trigger, you give a Gnrh agonist trigger, retrieve the oocytes, make the embryos, freeze them, and transfer them in the next slide cycle. Next slide. Next slide. Next slide. So this is how the this next slide. Next slide. This is all about hyperstimulation. Next slide. So, there are different categories of patient. One is the normal responders, the second is the PCOS, and the third is the poor responders. Next slide. So what is the progress in ART? One is to improve live birth rate, reduce complications of hyperstimulation, strengthen and automate the IVF laboratory, reduce multiple births, overcome IVF failures, give birth to genetically or epigenetically normal babies, do cost-effective IVF without affecting the outcome. This is very important. You can't compromise just because patient is poor, you should not. So how do you do that? By reducing your own charges. I never like to give substandard treatment to poor patients. The same treatment that you give to your mother, sister, or daughter, you should give to the poor patient and evolve new strategies. Next slide. So as you can see, we have had a very good experience with ART. Next slide. Our pregnancy rates in 3 cycles are as much as 90% live birth rate is there at the end of 3 attempts. So about 30-35% live birth rate per attempt. So there are a lot of disruptions that have come into the market. Next slide. Next slide. So there is the, as I told you, the MC technique. Next slide. So you can improve the sperm selection, I told you, by various techniques of electrophoresis, magnetic activated cell sorting, MC, Pixie, spindle check, and as I told you, the latest thing that has come is microfluidics. Next slide. And this is the various sperm selection procedures. I'll not go into it. Next slide. And this is the MC technique I told you, where we magnify the image 6,600 times. Next slide. And then inject the sperm, and you can see the spindle check technique. We use this technique also for oocyte freezing. So when we take the oocyte, once the spindle is formed and then you freeze the oocyte, the results are very good. So before we freeze the oocyte, we look for the spindle. Once the spindle is there, then only we freeze the oocyte. Similarly, when we thaw the oocyte, then before injecting them, we again wait for the spindle to reform. So we check for the spindle and then only we inject. Especially these patients who are cancer patients or patients who have done fertility preservation, you have to be very careful. Because you have got only 8 oocytes or 10 oocytes. So you have to have the best technique. You can't afford to have a failure of fertilization. So you must use all kind of technology for these patients. Another thing is the Blastocyst Transfer, which gives better pregnancy rate. Next slide. And the other thing which I use a lot in our unit, me and Dr. Nandita, is a double transfer. So many people, they come to us who have failed many times outside. Of course, I'm not saying that none of our patients fail. Many of our patients who fail also go to, let's say they may be going to Ajay Mane and becoming pregnant there. So it's a musical chair. Some people, they come, fail 2-3 times with us, they'll go to some other doctor and become pregnant. But when our patient come, this is a technique actually which I had evolved. And now a lot of my colleagues do the technique. When I started doing the technique 15 years back, they said, "Hey, kya karta hai Dr. Pai?" But this was Lutardi who started this technique of double transfer. So day 3, day 5 transfer, and it gives very good results. I mean, almost all the patients that come to me who have failed, I achieve pregnancy with this technique of double transfer. Next slide. And another technique I use, especially for failure patient, is laser hatching, which we introduced in 1998, first time in Asia. And now that time when I introduced, everyone used to criticize me, "Arey, Dr. Pai, what he has done." Now almost everyone has laser hatching in their centers, and you can use the laser also to cut the zona to do biopsy of blastomere or to do trophectoderm biopsy. Next slide. And this is the assisted hatching results of Tixer et al. There was a Cochrane review where they showed that patients with 2 repeated IVF failures, if you use laser, definitely there's an increase in pregnancy rate. Next slide. So this is another technique of embryo transfer, which we really evolved. And now, of course, a lot of people are doing this technique of the transfer, but we had really evolved this technique. And another technique is the technique of vitrification. Next slide. So vitrification is very important technique. I brought this technique in India in 2007. I had gone to clinic where Dr. Kumar of 2006, me and Dr. Rishma went to Japan. It was very costly. The taxi fare from the airport to the hospital was 10,000 rupees. So, but anyway, we went and learned this technique, and I brought it in first time in India. And then now, of course, everyone uses it very casually. But those were the days when really, we started introducing this technique, and so many people became pregnant. It was like a jadoo, I used to call it. I used to freeze the embryos and then transfer them, and the pregnant patient used to become pregnant. Next slide. So now many people want to do freeze-all. They say that the pregnancy rates are better if you do frozen transfer. Next slide. And this is a meta-analysis which they has shown that the odds ratio and all that is Bosdu's meta-analysis, which shows that but the normal conclusion is that there's a big meta-analysis that has come now from USA. Next slide. That they feel that in normal and poor responders, the pregnancy rates are similar, whether you do fresh transfer or frozen transfers. But in the hyper responders, the pregnancy rates are better with the freeze-all technology. Okay. The other thing is that we can do selection of the embryo using, so now a lot of people are going for single transfer, but if you do single blastocyst transfer, you must select the best embryo for transfer to get the best chance of pregnancy. So there are a lot of embryo selection technique. Next slide. But the commonest technique which we are using, one is the embryoscope you can use, and you can do time-lapse monitoring. And now there's a new artificial intelligence program developed by Trans et al, which can actually tell you which embryo to transfer. So that is a technique which is very popular now in the certain units in the West. But next slide, the standard technique is the biopsy technique. So you can do a embryo biopsy, trophectoderm biopsy, and then you do the genetic analysis using next-gen sequencing. During the COVID time, me and Dr. Nandita bought this whole DNA lab, nearly 2 crores lab we bought, and we invested, and it is such a beautiful experience. We are in loss with this lab at present, but it doesn't matter. Not everything in life you make money, but it is a great technology of next-gen sequencing. Next slide. And you can do a analysis of the trophectoderm. Next slide. And you can actually select the best, and this same technology can be also used for single gene defects. So we use it for thalassemia patients, sickle cell anemia, Duchenne muscular dystrophy, spinal muscular atrophy, and Fragile X syndrome, which are the commonest single gene disorders. So you can select the embryo, and which is a carrier or a normal can be put back into the couple who has had a previous abnormal child. Next slide. Next slide. Next slide. So this is another technique which we evolved. So instead of doing biopsy, you can take the culture media around the embryo, and the DNA normally leaks out especially when the blastocyst is formed and when it is expanding and it is in the process of hatching, the DNA leaks out into the culture media. So instead of doing a biopsy of the trophectoderm, you collect the culture media and amplify the DNA that has leaked out into the culture media, and then using next-gen sequencing technology, you analyze it. So without touching the blastocyst, actually, so it's a non-invasive technique. Next slide. And this we brought in, and it's a superb technique. But people who failed multiple times, I use this technique, and now huge series we have got. We are about to publish our first baby born following this technique. We had a publication last year in one of the international journals, and now we are publishing a big series of children And most of these patients who have come to me with 2 to 7 failures, IVF failures, we use this technique, select the best embryo and then transfer the embryo inside the uterus to get the pregnancy. Next slide. So these are other strategies for thin endometrium, mainly hysteroscopy or PRP or stem cell injection. Next slide. And so what is the future? One is fertility preservation. Another is creating gametes from stem cells. Next slide. I just wanted to show you the, so this is as far as the PRP now. This was again one of the first to introduce in India many years back. Now everyone uses PRP very casually. Next slide. Next slide. And then stem cells also, you can take the stem cells from the iliac bone, and there's a machine called Sepmax machine, sperm separator machine. You put the stem cells in the machine and it will, it costs about 25 lakh rupees. You just, it separate the stem cells and then you can take the fraction and you can inject it into the endometrium. You can just put it in the uterine cavity. You can inject it into the ovary. You can also do a transplant, and Dr. Puntambekar in India did our first Indian transplant. Dr. Match Branstorm did the first, especially for diseased uterus. You can use, or an absent uterus or a malformed uterus, you can use a uterine transplant, and this is going to be a big boom in the future now, especially because now cadaveric uterine transplant has been very successful. Next slide. As I told you, fertility preservation can be done for cancer patients or for other patients using oocyte freezing or ovarian tissue freezing. Next slide. Next. Is it stuck? Dr. Padesi? This is the Diana Hedden, Dr. Nandita's patient. She was, and in 2007, when we started doing egg freezing, she came and froze her eggs. She had a big endometrioma also, and she froze her eggs. And then later on, when she got married with the frozen eggs, she gave birth to 3 children. Next slide. Next slide. So again, ovarian tissue. Normally, when cancer patients are there, they don't have time to, stimulate them for 2 weeks and preserve their eggs. So instead of that, you go in with a laparoscope and do a hemi-oophorectomy and freeze the ovarian tissue. And then later on, after they complete their chemo radiation therapy and then they get married and all, later on, when they want to have children, you can retransplant the ovary back into the ovarian fossa. And that's why you need to do hemi-oophorectomy, because you need a bed in which to reimplant the ovary. So it's and this is the various ways you can create sperms from stem cells. So already in Japan, there is a group of people who are group of researchers who are doing stem cell work now, and they have been able to create the sperms and oocytes from the skin of mice cells, and they have also mice children have been born following this technology. Next slide. So again, ovarian rejuvenation is a big thing, especially now with the ERT bill, and egg donation will become very difficult. So a lot of people are coming to me for this PRP injection or autologous stem cell injection. And ultimately, all these people will be able to have children, next slide, through skin cells. So remember, these skin cells are going to be the future. In 7 years, they will be able to make the embryos but freeze the skin now. So difficult. Instead of using a fertility, you can go outside, because those will be old oocytes. Next slide. Next slide. I'm now nearly at the end of the lecture. Sorry, I'm delaying you people. Next slide. So there is another technology which is very exciting, which is the spindle transfer technology, which is for mitochondrial disease and now also can be used for poor quality oocyte. So you normally, if you do egg donation, you use the DNA of the donor. Instead of that, you take the donor and enucleate the spindle. I told you that we have already the machine of spindle check. So you can see where the spindle is. So you open the zona with the laser and put the syringe inside and remove the spindle, aspirate it out. Then you take the oocyte of the old patient, go back. You take the oocyte of the old patient and again open the zona and enucleate the spindle from the old patient's oocyte. Then you go to the donor oocyte, which is already enucleated, and you put the spindle under the zona and you fuse it. So Ajay, you will ask me, how do you fuse these two? So there are two techniques. One is known as the electroporation machine. So there's an electric current. So you give a high intensity electric current which fuses the two. And the other technique is that you expose them to a virus. There is a particular virus which can fuse as soon as, so we expose the spindle to the virus and we then inject it under the zona, and the virus activates the fusion of the cytoplasm and the spindle, and a new egg is formed. After that, you inject the new egg by XC and you create a new embryo. So this is the technique. Already 13 to 14 babies have been born in the last 2 years in Spain, and the clinical trials are going on, and to see how the milestones of the children are. Is there a problem with the children? And once this breakthrough is a major breakthrough for older age patient. Next slide. Instead of spindle, you can also do pronuclear transfer, which is easier because pronuclei can be visible on the microscope. See, for spindle, you need a spindle check machine to see where the spindle is. But if you don't have the machine, then you can take a donor oocyte and fertilize it with a donor sperm. Take a patient oocyte and fertilize with the husband sperm. After 1 day, that is 24 hours, both will develop pronuclei, which are visible on the inverted microscope. So you can enucleate the pronuclei and take the pronuclei of the patient and put them into the enucleated donor oocyte and again fuse it either with the virus or with the current. And once that is done, you have a new. First baby was born by this technique. It was a Leigh-Nian syndrome, and Johnny Zhang did this technique. He was from USA. This scientist, he went to Mexico and did this technique because USA does not allow embryo manipulation. Next slide. So this is the last few slides. So you can also correct the embryo. So nowadays what happens, suppose there's a patient with a dominant genetic disorder. So all the embryos are having abnormality. Now, normally if it is a recessive embryo, then what we do is we do pre-implantation genetic testing of the embryo, and the abnormal embryo you discard. But the carrier embryo or the normal embryo you can transfer back. But in patient with dominant gene disorder, all the embryos are going to be abnormal. So how do you do anything? So you have to modify the embryo. So instead of discarding the embryo, you correct the embryo. So this is at present not, it's in the experimental phase. So you correct it using the CRISPR technique. Next slide. And so this CRISPR technique, next slide, can be used for, first time even in humans it was used, and that scientist was put in jail for this technique. He used this technique and 2 babies were born, Lulu and Nana, following this CRISPR technique. But we all over the world, it is not allowed to transfer such embryos back into the patient. Next slide. Because there's something called off targeting. So what happens is that if you are correcting a particular gene, then you may also attack other areas in the DNA which are similar in character. So that is called off targeting. And so we are now making it more and more refined technique. A lot of experiments are going on. So specific targeting can be done. So there are new techniques that are coming in to replace CRISPR, which are called base editing. So they are more targeted techniques. And next slide. So this is ultimately we want to have a child by exogenesis. Means you can have the child totally outside the body. And there's no criticism that higher incidence of cesarean sections is there, etc. So you have a nice container and you have all the nutrients. And next slide, this is Nandita's presentation. So I've been borrowing it. So this is her family's photograph. Next slide. So basically, next slide. Next slide. So basically the exogenesis. Next slide. Yeah. Next slide. This is you can terminate the presentation. Dr. Padeshi just put on the screen. So, basically what I'm saying is that the exogenesis is the ultimate vision. So it's going to be easily possible. We'll be able to do 3D printing of the placenta, and we'll be able to have a container wherein the placenta is there and the embryo. Already new experiments they have allowed that the embryo can be cultured till 14 days. So there was a moratorium on embryo culture till 7 days. Now experimentations are allowed till 14 days. So we'll be able to create a baby and culture it. Blastocyst is 5 days, so we'll be able to go till 14 days, and then that baby will implant it into a 3D placenta in a container, which will have all the nutrients and oxygen will be there, and slowly the child will develop, and it will implant on the 3D placenta, and it will form the placentation. And then later on, and when it is 9 months, we will be able to just open the lid and deliver the babies by just opening the lid. No need of doing cesarean section. So this is going to be possible in the next 25-30 years, I'm sure. So I don't want to delay anymore. Thank you very much, Ajay and Rajendra Singh, for calling me here and sharing my views. Unfortunately, I didn't have my presentation, so I had to request Dr. Nandita, and they sent the presentation, and then I presented you the presentation. So some of our photographs are there. Thank you very much for the patient hearing.
Thank you so
Sir,
much,
thank you
sir.
very much. Thank you, sir, for sparing time in spite of your busy schedule. I know you are in hospital. Thank you, sir. Thank you very much.
Sorry to trouble you a lot.
Yes,
We are, by the way, for all of you who are there, I know both Dr. Ajay and Dr. Rajendra for a long time. We are what you call in your the term, we are all dinosaurs. So we are, in the final phase. Ajay is still young, but me and Dr. Rajendra are in our final golden phase of life. And we wish that all of you, we are such lucky. All of you have all so much technology. Of course, our excitement was that we saw everything in. I was in KEM when I saw I was the person who was there when my boss, Dr. Andy Motasha, had the first hysteroscopy workshop in India. So just a funny story I want to tell you before I sign out. So I was the houseman of Dr. Andy Motasha. She was my thesis teacher, and she had in this first hysteroscope workshop in KEM hospital. And I was there, and this patient was there, and Dr. Mahendra Patel, who was the then Secretary General, was also there, and we were all seeing there was no camera. So I said, "Aankh mein laga ke hum dekh rahe the." Arey. So Dr. Mahendra Patel was seeing in the hysteroscope, and she said, "Arey, kya acha dikh raha hai, bahut acha." I said, "Sir, मेरे को भी दिखाओ ना, क्या दिख रहा है, देखने दो." तो मैंने देखा, मैं बोला, "सर, ये तो fundus perforate करके bowel दिख रहा है." So we had perforated the fundus, and nicely the bowel was floating in the pouch of Douglas, and we were seeing that bowel. So that's how it was there. And when I was Dr. Rawal's registrar, first ultrasound machine had come to BPT, second machine had come to Gnrh Hospital. I was his lecturer. Then he said, "Rishikesh, and I didn't have the lecturer post. I was well, I didn't have any job." So he said, "Arey, एक ICMR का post आया है, ultrasound machine का नया machine आया, तो तू बैठ जा." So I did nearly 5,000 BPD. मैं इतना expert हूँ ना, BPD 10 सेकंड में कर सकता हूँ. BPD, I used to do BPD, femur length and abdominal circumference. खटाखट कम से कम 5,000 वो टाइम में 1987 में मैंने 5,000 अल्ट्रासाउंड किए हुए. I was ICMR research fellow. Dr. Rawal, my boss, said the second machine in India का second machine था ये. So this was the excitement those days. All new technology was there. So thank you very much.
Thank you, sir. Sir, I was the post-PG resident trainee of infertility training in Mumbai when you brought that laser hatching. Yeah, I learned it in Jaslok Hospital.
Right.
In 1999.
So,
the second machine was there.
Fantastic. I know. So, हम सब बुजुर्ग हैं, तो आपको सबको हमारी दुआएं हैं.
Thank you, sir. Thank you very much. Thank you very much for.
Okay. Thank you. Allow me to take your leave. Bye.
Yes, sir.
Thank
Achala,
you.
madam, are you there? Achala, ma'am.
Manju ma'am. MOC.
Manju, ma'am.
Karishma.
Achala, madam, are you there? Yeah. Madam, your comments.
Sorry, I was not there for my comments on what are you asking? I just
Rishikesh sir's lecture.
Oh, who am I to comment on his lectures? His lectures are always very fantastic, and he's been giving lectures since many years in Delhi, and especially his double transfer technique,
3 and 5
has shown, and many other things also, something innovative he does, which are showing very good results. It's always a pleasure to listen to him, and he's very crisp and clear about the message he wants to give. And of course, there is a need for this new kind of innovations in ART. That was a very good lecture covering the recent aspects in ART and also the old ones.
Yes. Thank you.
Manju
Thank you very much.
Thank you, ma'am.
Manju Jilla, ma'am.
No, I think she is gone. Okay, over to you, Karishma.
Yeah, thank you. Moving on, I would invite and introduce Dr. Meenal Chidgupkar and Dr. Shivani Gaur to chair the session as chairperson. Dr. Meenal Chidgupkar, MBBS, DNB, FCPS, DGO, and MS OBGY. Of Dr. Chidgupkar Hospital Private Limited, Solar, Senior Infertility and IVF Specialist at Apollo Fertility, Solapur. 12 years of experience in infertility and laparoscopy. MBBS from Seth GS Medical College, Mumbai. DNB from LTMC Sion Hospital, Mumbai. Diploma in Infertility and Laparoscopy from Kiel University, Germany. Fellowship in Reproductive Medicine and Advanced Laparoscopy from NHS, England. Worked extensively in fields of adolescent health, pre-cancer detection, and women health. I would request Dr. Meenal Chidgupkar to introduce and invite Dr. Vikram Lokhande to talk on intrauterine surgeries in an infertile woman. I'm sorry, pardon me. Over to you, ma'am. Do we have
unmute? Yes, ma'am.
Yeah. Thank you so much. At the onset, I would like to thank Dr. Padeshi and Dr. Mane sir for giving me this opportunity. They are like my mentors, and in my all academic work, they always support me. Thank you so much. Now I would like to invite Dr. Vikram Lokas. He taught us so many things, and he is at present director at Niramai 3D Laparoscopy Center, Aurangabad. Teacher of fellowship in basic and advanced 3 months course. Then gynecological endoscopy at Narayani 3D Laparoscopy Center, Aurangabad. Teacher of short course for hands-on basic laparoscopy and hysteroscopy procedures. State representative of Aurangabad OBGY Society, special interest in dramatics, and he is a hardcore poet. Thank you so much, and I would like Dr. Vikram Lokhande to speak about his topic.
Welcome, Vikram. Dr. Vikram is a very student-friendly teacher in MG Medical College, Aurangabad.
Just a minute.
Yes, Vikram, over to you.
Is it visible, sir?
Yeah, no, slides are not visible. You are visible.
How to share this then?
Sir.
Yeah, you open the PPT, minimize it. Minimize केलं?
Yes, sir.
हाँ, आता खाली जा. सगळ्यात खाली हिरवं बटन आहे बघ. शेअर स्क्रीनचं. सगळ्यात खाली बॉटम लाईन. अरे सगळ्यात खाली.
तुमच्या झूम मीटिंगचं जे पेज आहे ना सर, त्याच्यावरती आहे बघा.
ओके, शेअर द स्क्रीन, गॉट इट.
हा, शेअर द स्क्रीन त्याला क्लिक कर. तुला विंडोज दिसतील सगळ्यात. तुझ्या प्रेझेंटेशनच्या विंडोला क्लिक कर.
राईट.
आणि त्याला शेअर नाव येतं राईट लोअर कॉर्नर. त्याला विंडोला क्लिक कर पहिले तुझ्या प्रेझेंटेशनच्या.
येस सर, इट इज ओपन्ड. ओके, हा शेअर राईट.
हा, शेअर नाव. शेअर करते.
नो
नाही, शेअर नाव कर ना, त्या विंडोला क्लिक केल्यानंतर खाली राईट लोअर कॉर्नरला शेअरचं बटन आहे परत.
शेअर स्क्रीन सर. ओके.
हा,
डेस्कटॉप
स्क्रीन झालं ना की तुला
शेअर.
डेस्कटॉप व्ह्यू नाही, तुझी पीपीटी मिनिमाइज केलेली दिसते का समोर?
येस सर.
हा, त्याला क्लिक कर एकदा.
ओके.
हा, आता राईट लोअर कॉर्नरला शेअर येईल परत, छोट ब्लू कलरचं बटन आहे, शेअर नाव.
गेटिंग सर.
विक्रम,
वेर इज दॅट बटन सर?
विक्रम एकदम खाली गेला ना तू, ब्लॅकला खालचे बघ तू, तुला पार्टिसिपंट दिसत आहेत 68?
नो सर.
खाली एकदम खाली जातो.
स्क्रीनवरती कर्सर हरव, तुला सगळ्यात खाली लाईन.
येस सर.
खाली जा. हा, तिथे चार्ट आहे बघ समोर, चार्ट आहे बाजूला, QA
राईट.
चार्ट.
हा नाही, शेअर केलं सर स्क्रीन, नंतर मग डेस्कटॉप वन येतं.
हा, डेस्कटॉप आलं ना वर, त्याच्या बाजूला तुझं बघ ना, तिथे प्रेझेंटेशन आहे तुझं. बघ तिथे आहे ते प्रेझेंटेशन येईल तुझं. तू जिथे क्लिक, तू डेस्कटॉप, बरं तुझं जे उघडलंय ते डेस्कटॉपवर उघडलंय ना तू प्रेझेंटेशन?
येस सर. हा हा.
का माय डॉक्युमेंट मध्ये?
नाही सर, हे डेस्कटॉप वरतीच आहे.
हा, बघ मग त्याच्यात ते प्रेझेंटेशन येईल ते तुला.
आय डोंट नो व्हॉट हॅपन.
व्हिडिओ आहेत का तुझ्या ह्याच्यामध्ये?
सर व्हिडिओ ते डाउनलोड नाही झाले, समथिंग हॅपन. नाही सर, नाही होते ते, पण डाउनलोड नाही झाले ते.
नुसतं प्रेझेंटेशन आहे का?
हा.
माझ्या मेलवर पाठवतो का, मेल करतो का मी इकडून दाखव? तू बोल तिकडून वाटलं तर.
राईट
सर. डॉक्टर माने अजयला पाठव.
तोपर्यंत ट्राय करतो. DR माने अजय @gmail.com ला पाठवून दे लगेच.
राईट सर. सर हे बहुतेक काहीतरी प्रॉब्लेम झाला. ठीक आहे.
मेलला पाठवला का?
नाही सर, ते येणार नाही.
नाही, मेलला केला का? मेल केला का? होते ना 2 मिनिटं, काही नाही, डेलिगेट्स थांबलेले आहेत, काही प्रॉब्लेम नाही, टेन्शन घेऊ नका. मेलला पाठवला का?
आम्ही बघतोय सर ते.
याला मिनिमाइज करून टाका ना पूर्ण विंडो आपला झूमचा, आणि मेलला पाठवा, आणि त्याच्यानंतर पुन्हा ट्राय करा तुमचं शेअर स्क्रीन. होतं ते, माझे फुल विंडो होतच नव्हतं, काहीतरी प्रॉब्लेम होता. चालतं ते. याला मिनिमाइज न करता पूर्ण उघडून ठेवा त्याला नुसतं, याला फुल स्क्रीन करू नका. तसं करा आता, फुल असं उघडून ठेवा प्रेझेंटेशन फक्त.
नाही, उघडलेलंच आहे सर ते.
आता शेअर स्क्रीनवर जाऊन डबल करा ना क्लिक शेअर स्क्रीनला.
एकदा मेल करून टाकतो अजय सरांना.
आधी मेल करून टाका लगेच.
तुम्हाला करू का सर?
नाही, अजय सरांना करा, मलाही करा, दोघांनाही करा. माने सरांना करा. DR माने अजय @gmail.com.
ठीक है मिनट सर.
मंजू मैडम आहेत का?
गूगल फोटोज के सब डिलीट कर देती हूँ उसमें से, तो मेरा फोन एकदम खाली हो जाएगा.
करिश्मा मैडम म्यूट करो. करिश्मा म्यूट करो.
मेल येत नाही सर तो.
बरं जाऊ
जाऊ द्या सर मग. ओके,
माझ्या मेलवर टाका ना.
ओके.
किती मोठी फाईल आहे का ती?
बहुतेक ते व्हिडिओज मुळे येत नसेल सर. त्याने व्हिडिओ
नाही आता पुन्हा एकदा ट्राय करा शांततेने. लोक बसलेत कारण तुमचं इंटरेस्टिंग टॉक आहे आणि ते व्हिडिओ तुम्ही जरी मेलवर पाठवलं तर व्हिडिओ येणार नाही ना. आता काय करा, हे ओपन करा. हा, मला पाठवायला ट्राय करा. कसं आहे करा. परदेशी राजेंद्र सिंग माझा आहे ना मेल?
येस सर.
परदेशी राजेंद्र सिंह @gmail.com. GH आहे. काय नाही, काय होऊ द्या. लोक आहे वेटिंग आहेत सगळे.
परदेशी
राजेंद्र
ते यायला पाहिजे. तुमचं आहेच ना सर.
राजेंद्र सिंग SINGH. यच करा फक्त.
येत नाही सर ते.
बरं जाऊ द्या, हे करा ना पुन्हा. नाही ट्राय करा ना पुन्हा एकदा. ट्राय होईल, काही नाही प्रॉब्लेम. हा, आता करा. शेअर स्क्रीन करा. डबल स्क्रीन करा त्याला.
ट्राय करून बघतो सर.
डेस्कटॉप दिसतोय का मला सांगा. डेस्कटॉप आता डेस्कटॉप दिसायला लागला का शेअर स्क्रीन केल्यावर? याच्यावर दिसायला पाहिजे पुन्हा झूम. दिसतोय का?
तुमचं दिसतंय सर मला. आता मी हे केलंय. ओके.
नाही हा, तुमचा डेस्कटॉप दिसायला पाहिजे. दिसतोय का?
हा, राईट सर.
आता त्याच्यात प्रेझेंटेशन बघा ना. त्या मॅडमला सांगा, तुमच्या बाजूला मॅडम आल्या त्यांना सांगा, बसवा त्यांना. त्यांना बसवा त्यांना. त्यांना येत असेल त्यांनाही बसू द्या. हा, आला का डेस्कटॉप? आला का?
हा, आला सर. आता डेस्कटॉप.
आता डेस्कटॉप आला. आता तुमचं ते शोधा. तुमचं नाव काय दिलेलं आहे त्याला तुमच्या प्रेझेंटेशनला?
PPT सर.
हो ना, त्याला नाव काय दिलेलं आहे? त्याला क्लिक करा मग. हॅलो,
नाही ना.
विक्रम, तू प्रेझेंटेशन ओपन केलंयस का सगळ्यात पहिले?
हा, राईट सर.
अरे ऐक ना दादा, तू प्रेझेंटेशन ओपन केलंयस का?
येस सर. ओपन आहे ना सर.
केलंयस? ओपन करून मिनिमाइज केलंयस का?
हा सर.
हा, आता ह्याच्यावरती शेअर स्क्रीन कर तर तुला बाकीचे विंडोज दिसतील काय काय ओपन तुझ्यात. खालचं शेअर स्क्रीन दाब. हिरवं खालचं बटन, सगळ्यात खाली हिरवं बटन आहे. आता तुला ते प्रेझेंटेशन दिसतंय का मिनिमाइज केलेलं? एक विंडो दिसेल.
नाही दिसत ना सर. ते नाही दिसत ना.
ती प्रेझेंटेशनची विंडो दिसायला पाहिजे ना.
हा, ते माहित नाही.
परत जा, स्टॉप शेअरिंग कर. सगळ्यात वरती बटन आहे, स्टॉप शेअरिंग. सगळ्यात वरती.
ओके, कॉपी करतो सर. एक मिनिट.
हा, कॉपी कर. स्टॉप शेअरिंग कर. परत एकदा कॉपी कर.
राईट.
नाही, कॉपीवर जर क्लिक केलं तर होणार नाही. ते मेन प्रेझेंटेशन पाहिजे. हा, तिथे कॉपीवर होतं का ते क्लिक? त्याला मेन त्याच्यावर करा ना. म्हणजे डेस्कटॉपवर त्याला कॉपी करून पेस्ट करा.
येस सर.
हा, त्या प्रेझेंटेशनला. आता ओपन करा. त्याला राहू द्या, ओपन राहू देईल तरी.
येस सर.
हा, राहिलं. ओपन झालं. फुल स्क्रीन करू नका, नुसतं ओपन करा.
नाही होते सर. ते तर प्रॉब्लेम आहे. ठीक आहे सर. इट्स ओके.
नाही, एक काम करा ना. तुमचे स्टाफ कोण बाजूला सांगा, त्यांना बसवा ना. ते कोण आहे बाजूला होता? डॉक्टर.
नाही, शी इज माय फेलो सर.
हा ना, हो ना, त्यांना करता येईल. उलट बसवा त्यांना. त्या करतील. बसवा त्यांना.
राईट.
शी विल डू. कारण नवीन पिढी ना, न्यू जनरेशन, दे विल डू फास्ट.
हा, अरे विक्रम, मला आडलं ना, मी संग्रामला विचारतो माझ्या पोराला, हे अरे इथे अडकून बसले, काय करायचं?
राईट सर.
दे आर मोर एक्सपर्ट दॅन अस ऑलवेज.
राईट सर.
आणि इट इज अ मियर क्वेश्चन ऑफ प्रॅक्टिस बेसिकली. आपण रेग्युलरली
use
लॅप्रोस्कोपी
to
करतो. मी लॅप्रोस्कोपी करत नाही. मी जर लॅप्रोस्कोप घुसडला तर पलीकडून निघल. तुम्हाला सवय आहे त्याची, आम्हाला सवय नाही. असं लाईकवाईज इट हॅपन्स.
आणि लोक वेट करताय अजूनही बरोबर, कारण ते तुमचं प्रेझेंटेशन इंटरेस्टेड आहे ना.
माहित नाही सर काय ते तुमचं जे येतं ना खाली ते येतच नाही येतं शेअर स्क्रीनचं. शेअर स्क्रीन येतं ते, नंतर शेअर स्क्रीन केल्यानंतर खूप फाइंडर येतं त्याच्यात. पण आता बेसिक्स मध्ये आता डेस्कटॉप मध्ये ते यायला पाहिजे ते तसं. ओके नोट फाइंडर.
तू बाकीचं बंद कर ना. बाकीचे खाली तुझे खूप उघडून ठेवले असेल ना, सगळे बंद कर.
बंद कर,
ओपन कर.
नाही सर,
सगळ्या विंडो बंद करा बाकीच्या.
नहीं सर विंडो नहीं से ओपन.
फाइंडर ओपन कीजिए ना, यहाँ से ये फाइंडर ओपन.
विक्रम त्यांना बसू द्या, तिथे बसून करू द्या. लेटर डू माझा ऐका, त्यांना करू द्या.
फाइंडर में नहीं जाके.
हाँ यस. हाँ see open the presentation on the
इसमें जाइए.
paste the on the presentation should be on the desktop only.
You have to open this via this.
ये प्रेजेंटेशन है.
Yes.
राइट. अभी इसको मिनिमाइज किया. 4 प्रेजेंटेशन हो गया. राइट.
then share the screen.
ओके ये यहाँ पे है शेयर द स्क्रीन. राइट. अभी ये आया तो आ रहा नहीं ना यहाँ पे. ये चलिए ये शेयर कंप्यूटर साउंड क्लिक करना पड़ेगा क्या? ये कीनोट वगैरह डोंट नो है. सर ते येत नाही सर तिथं ते ना.
थांब लेटर ट्राय
तुम्ही त्यांना बसू द्या. त्यांना बसू द्या, बसून करतील त्या. बसू द्या, कारण तुमचे व्हिडिओ इंटरेस्टिंग आहेत. people are waiting for that video.
Sir can log out once and rejoin again, sir.
that will be there.
Right, I will try.
Stalin, what may be the problem?
विक्रम त्यांनी काय सांगितलं, लॉग आउट होऊन परत जॉइन कर.
ओके सर.
हा लॉग आउट करा तुम्ही, पूर्ण लॉग आउट करा आणि पुन्हा एकदा मीटिंगला जॉइन व्हा.
पूर्ण बाहेर म्हणजे लीव द मीटिंग करायचं. लीव राईट लोअर कॉर्नर.
आणि मेक हिम को होस्ट. स्टॅलिन, Chandrika.
Yes sir.
Make him co-host so that will be easy for him to share. Because his presentation is very interested. Videos are there and people are waiting.
Okay. Till that moment, I just wanted to say you the take-home message from my presentation. Basically,
yes.
ART practices, you should continue doing the things because they have not ordered us to stop the things. First thing. Second, go according to your previous strategy. Everything must be a genuine one. Then third, as soon as they form the registry process, the central supervisory board and the state board and the district level board will be under civil surgeon or the joint director or the chief medical officer of the corporation area. As soon as they form, you apply for the registration. Within a few days, though they have given us 2 months, you apply as soon as possible and wait for them because they have very less time, because it is a starting of the new horizon. So all processes, all the applications will be flooded in the office and they won't get time to inspect, to scrutinize your then, and if they get late, they will blame you. So as soon as it opens, you apply for it. Okay, that will be my advice.
Mane sir, can we do IUI?
No sir, basically IUI is incorporated in the ART process. No, so in routine obstetrics and gynecology hospitals, we are not allowed to perform IUI. IUI must be in the ART hospital only.
That is correct, but not donor. But
no, husband semen also it is not allowed.
Why?
It must be in a primary ART clinic.
Exactly, and that we have to register with ICMR also. Then this registry
yes.
there.
No, sir. No ICMR now. See, previously it was with ICMR. Now no ICMR. only registry will be with the state authority, appropriate authority.
Whether we can take eggs from surrogacy from others?
No, no, no.
Same surrogacy. Suppose we decided
we cannot we cannot use the oocyte from the surrogate mother.
Exactly.
Yeah.
And what amount is decided by government, or we have to pay? Means in that.
For what?
Surrogate mother. Government is deciding some amount.
Basically, see.
What are the criteria?
Basically, commercial surrogacy is not allowed. So no amount is mentioned. We can bear the medical expenses. We can bear all the investigating expenses. We can bear all the rest of the expenses. The insurance purposes, they have given that the insurance must be done of a surrogate mother for 3 years, 36 months they have given. In ART, the donor was of 12 months, but in surrogacy, it is of 36 months. That is a 3 years insurance. If something goes wrong, or death of the surrogate mother, or anything, they have given us 36 months. So 3 years insurance must be done by the couple or
Dr.
the intending woman.
Dr. Mane sir, many people, they are asking questions, not related to ART, but now the government is in a mode of making age of marriage is 21. Now we are facing the problem, 17 years, 16 years, they are coming for delivery. So after 21 years, how doctors should conduct the delivery? Every patient, they have to inform police what to do.
Sir, basically, see, the Pco Act covers the pregnancy less than 18 years old. If she is above 18 years, it is no problem till today, though married or unmarried. But if she is married or unmarried, less than 18 years, has to be informed to the police in written format, because the Protection of Child from Sexual Offences Act, that is Pco Act 2012, amended in 2019, it states that we must inform the police or the child welfare committee if we come across such a situation. If we do not inform them, there is a provision of 6 months imprisonment for the doctor. So we have to inform. And see, as you said, if the government make a age of marriage 21 years, it will be more difficult for us, because see, the children or the adolescents, they are not following proper ethical issues regarding this sexual activity and the protection and the contraception. Government on one side says that less than 18 years must be informed to police, and on the other side, on website, they give the contraceptive advice to the adolescents. So this is a controversy by the government also. Okay, so making age 21 years will create a havoc. It must be 18 years as if today.
So we should do something in this matter, and all women's organization also, we should initiate something, because it will be a havoc for doctors also, for the society also, and for doctors also. So the
because see, everybody gets escape from the trap, but the doctors cannot get. Exactly. So they are entangled with the difficult situations. Likewise in PCP and DT. See, in PCP and DT, so many doctors are harassed, so many doctors are punished. But show me a single relative of a woman who is punished for this demanding of sex determination. Not a single in whole India. Why this is disparity? Only doctors are punished, and why not the relatives? The provision is there in law that the relatives who bring the mother for the sex determination must be punished. But government is not keen to punish their relatives. Are we going to call them from home ki nahi, aa jao yahan pe determination kar lo? No, we are not going there. But they are bringing. Doing the sex determination is wrong thing. I know. Very few people, 1 or 2% of doctors, they are doing, and all are victim of that trap basically. But the relative should be punished.
Hello, Vikram.
And see, one question was there from one society, that no letter from the appropriate authority for the amendment implementation of the MTP. See, when the amendments are published in Gazette, So it is considered as implemented. No special letter is required. This is a message for all the society president, secretaries, and delegates who are listening. Please ask your civil surgeon or joint director or the MOH to implement the latest amendments in MTP. Okay? There will not be a separate letter from your director, state or director, national family and health, family welfare ministry regarding this. Okay.
Manesha, some complaints are there. MOH from some means 2-3 societies, they are telling that new certificate should be necessary. Up to 20 weeks certificate there, so 24 weeks.
Okay, okay. Sir, so in Gazette, they have published that the word 20 must be replaced by the 24. Means it is considered that whosoever, see for an example, your hospital is already given the certificate of second trimester abortion. Previously, it was 12 weeks to 20 weeks. Now it should be considered as 12 weeks to 24 weeks. There is no need or no necessity to give the or submit the old certificate to the appropriate authority and get a new certificate. But at some district, the authorities, they have demanded that please submit your old certificates and we'll reissue the newer one. But mind it, no charges are applicable for this. It is a free of cost service from the government, but as much as possible, it is not needed. You can continue with the old certificates.
Manesha, one gynecologist patient come with the complaint of pain in abdomen many times and pain in abdomen.
Yes, sir.
Age is 16 to 17 years, and for diagnosis, he put a scope inside, and he found a mass, adnexal mass, small mass. He removed this mass. Patient discharged, and the report comes as chronic ectopic. What to do next? And
okay. Basically, she is 16-year-old, no? So it comes under Pco Act. And see, initial phase, the patient did not give the history of sexual activity, did not give history of any contact. So we are not God to know all the things. So he removed the mass, sent it for histopathology. The report came as a chronic ectopic, means the pregnancy less than 18 years. At that moment, he should inform the police or the child welfare committee that such and such incidents happened. We sent the histopath, and the histopath report came as it was a pregnancy. Though ectopic pregnancy, whatever, but it was a pregnancy. So at that moment, he should inform the police with a return received from the police. That's all.
If he doesn't report, what will be the consequences?
Yes, if he do not report, then 6 months imprisonment can be there for the consultant. It is a provision in the Pco Act. 6 months imprisonment. That is very dreadful punishment they have given.
There are many problems. Legal
there are
problems.
Many problems. We doctors are at the aim of the all agencies.
And many now see in 1917 one act, we can decide when to do MTP, right? But nowadays they are telling sonography is must.
No,
Why?
sir. We see basically what happens
Before doing
in law.
MTP.
They have no. In law, they have not given that sonography is mandatory before MTP, but sonography is advisable before MTP. Why? There are two reasons. One reason, it indicates, sorry, it shows basically where the pregnancy is, whether intrauterine, whether extrauterine, whether heterotopic, intubal, or in tube or peritoneum, whatever. But it shows the location of the pregnancy first, because many times it had happened. We have seen in the cases that the pregnancy is in tubes, and the medical method of termination is given and the tube is ruptured and patient went into the shock. This is first thing. Second thing, we can have a proper gestational age. Say for an example, you are having first trimester abortion, patient come at 11 weeks and actually it is of 13 to 14 weeks. And if you terminate the pregnancy, the authority comes and got proved that pregnancies of 14 weeks, you are at fraud. So it is a tip to you that you should have a MTP, sonography before having a M2 basic. See, and one more provision is there in amendment. They have given that failure of contraception provision, which was there for married women in previous law. But nowadays in amendment, they have given that it is available for unmarried women also, but up to 20 weeks only. It is not available beyond 20 weeks. Beyond 20 weeks, there are indications they have given in Form E, which are most of the time a rape case, minor pregnancies, and all the congenital anomalies. These are included in indications of Form E, 20 to 24 weeks. And after 24 weeks, we need to go in front of the medical board, where medical board has to give decision within 3 days, and the pregnancy must be terminated within 5 days. So 8 days procedure is there to terminate the pregnancy after going to medical board. So after 24 weeks, medical board, 20 to 24 weeks, Form E, up to 20 weeks, Form 1. That is not Form I, that is Form 1. Okay, old one. And Form C is mandatory for all types of MTPs, whether it is a medical line of termination of pregnancy, whether it is a surgical. Form C is mandatory. You can have another format additional to this, but C is mandatory. Form 1 and Form C, or Form E and Form C is mandatory. You need to keep this along with your indoor paper. Keep all the bunch in the envelope, seal it, write down your name, date, patient's registration number, not the name. Once you enter the patient's name in the Form 3, that is the MTP register, you need to give a number to the patient, and then onward you use only that number. Never write down the patient's name on a prescription or on the discharge card or the documents, anything. If the patient demands a certificate mentioning her name on that in written format, then and then only you issue a certificate for insurance purpose or for leave purpose to the patient, not to the husband also. To the patient only, you need to give and hand over to the patient only, and get a receipt from that, ki such and such document and certification with my name received from Dr. Rajan Singh Pardesi. Okay, that is there. So this confidentiality is to be maintained, and if the confidentiality is not maintained, there is a provision of 1 year imprisonment in the new amendment. Okay, previously it was only 1,000 fine, but now it is a 1 year imprisonment. So maintain the confidentiality. Don't show the patient's paper to anybody except civil surgeon and MOH and the authority given persons.
Recently,
Yes,
in our society, Mane sir.
Sir.
So police send notice to doctor. Just 1 minute.
For
Doctor, hello Vikram. Hello. But ठीक आहे चल मग आम्ही एंड करून घेतो, काही प्रॉब्लेम नाही. ओके. Police send notice to one doctor, means they on the phone only. You come over there at one place, means it is 60-70 kilometers, and give the details. Means inquiry about the patient. Abortion, you have done abortion, and you have to come for the inquiry. The inquiry officer told you have to come here.
Yeah.
In spite of telling him this is a case of MTP, what to do?
I understand the situation. Basically, see, MTP is a cognizable offense, so the investigating officer can demand the documents. We need to give documents to the investigating officer. That is a necessity. Okay, that is a power given to him by the law. We need to give him in 1, 2, 3, 4, 5 numbering and hand over the photocopy. Don't hand over the original paper. Keep the original paper with you. Hand over the photocopy. Get a receipt from that person, maybe a Havaldar or the Chowki or Jamadar or whatever, and get a receipt from that. But you need to give the paper after applying to your hospital in written format. Means get a written application from them that they need the documents, not on oral order, not on phone order. Get a written format that they need, and then only give a covering letter that this is a confidential document. To keep the confidentiality is now your duty. Mention this sentence in that letter and give it to the police. Second thing, if they call you for the statement, you request them that I am very busy person, I cannot leave my hospital, there are waiting patients in labor, so it is my primary duty. You send your person and tell it politely. Don't insist that, tell it politely that send anybody, and he is not an emergency, so he will send one or two person maybe for the statement and give the statement, sign it, read it first and sign it. Many of us, what we do, we tell the story, the Havaldar go on writing the things and yahan sign kijiye. So we write, sign there. No, before signing, read word to word what they have written. They may have missed something or they may have added something. I'm not blaming, but this can be lack of communication. So read word to word and then only sign it there. Or else, if needed, they insist. With your leisure time, you fix the time and go to police chowki, give the statement and come back. But don't have a quarrel with the police, because it will be a difficult matter. But it is not mandatory to you to go to police station urgently. Okay, with your leisure time, you can do that, or call the person to your hospital and give the statement. Don't worry, they won't do anything, because you have followed the law. You have followed major age is 18 years. So you have terminated the pregnancy after 18 years. Okay. You have terminated under the proper clauses. You have terminated according to the law. So don't worry. Don't be afraid. डरने की बात नहीं है. And if something goes wrong, call me. Police को डरना नहीं है. Okay. Best.
So one question is there. I mean, it's a quite
Sir,
common
the
question.
people will beat me now. I'm taking
No,
too much time
sir.
of them.
No, now it's a discussion only now. We are discussing, we are taking your time, sorry. So one question is there. It's a common question. Many times the patient comes and the cases has been done. 2-3 cases and they denied on the MTP. These are cases, no, illegal abortion kar diya, aisa vaisa, and they denied, this is not my signature. What to do?
Yeah, for this there is one solution, sir. Basically, we take a signature of the patient, okay, and we proceed. But the tip is that take a left thumb impression beside that signature, because they may deny the signature, but they cannot deny the thumb impression. Okay, we can prove that this thumb impression belongs to this fellow. Second tip is that ask the person who is signing there to write the name of the person below the signature in their own handwriting. They cannot deny the handwriting also. Okay, these are the two tips. Take a left thumb impression, or take a ask them to write their own name below the signature. These are the two things which can save you from this situation. They cannot deny this.
In many cases, in court cases, they are telling doctor's signature is also must on consent.
Obviously, why? Sir, consent. See, consent is a document. It is a basically agreement between two persons. One is doctor and second is patients. If one signature is missing, then it is incomplete document. So patient signature is important or needed, doctor signature is needed, and the witness is needed. Why witness signature? Because witness says that this signature is being done in front of me. That's why. The witness is nowhere related with the case, diagnosis, treatment, or anything. He says that this signature is done in front of me. That's why. So have two witnesses, one from patient side, one from your side, but the patient's and doctor's signature are mandatory. Then and then only the consent is complete, or it is incomplete consent.
Thank you, Dr. Ajay Mane, sir.
Thank you, sir. Thank you very much. Thank you very much.
Due to some technical problems, apology
I think,
from
Vikram
Dr.
is
Vikram
unable
Bhavan.
to show the presentation.
So you can proceed for the Thanksgiving.
Yeah, Karishma.
You can proceed for Thanksgiving, Dr. Ajay.
Okay, sir. Thank you very much. Thank you. At the outset, I convey my gratitude to Achala Batra madam, who is the chief guest and guest of honors, Asha Rao madam, then Rajeshri Palade madam, Vinda Singh madam, and yourself, Dr. Rajendra Singh Pardisi, and the organizers, Yashwant Pawar sir and Mandar Karambekar sir, and the chairpersons, Dr. Shivani, in spite of her busy schedule, she has agreed to come and she came. Adinath, in spite of his health problems, he came. And Dr. Meenal, who was on journey, came as a chairperson. Thank you very much. And the greatest speakers, Rushikesh Pai sir, Dr. Manju Jilla madam, and unfortunately Vikram could not do it, but he is also a great speaker. I convey my gratitude to all of them. And thank you all delegates, and thank you Dr. Stalin from Shield Healthcare and Dr. Karishma for the smooth handling of the webinar. Thank you very much. And I convey my gratitude to Mahesh Tandale, who is the MMC observer today. Thank you, Mahesh, for being there. And last, thank you very much, Rajan Singh Pardesi sir, for bringing all of us together. Thank you very much. Good night. Stay safe.
Good night.
Thank you, sir. Thank you very much for the opportunity, sir.
You can close.
Thank you, sir.
Any question in chat box? No. Okay, we can end that.
Yes, sir. Thank you, sir.
Thank you.